Good afternoon, everyone. Okay. Good afternoon, everyone. I'm Dr. Prerna, and I welcome you all for this year's midterm thoracic CME. Continuing with our pre-lunch sessions, I request our respected moderators, Dr. Rajan Santosham, Chairman of Santosham Chest Hospitals and Senior Consultant Thoracic Surgeons in Apollo, Chennai, and our Director, Dr. Ravindra Kumar Diwan, sir, to kindly moderate this session. I also would like to invite Dr. Dr. Rajiv Santosham for his talk on approach to superior sulcus tumors. Dr. Rajiv Santosham is a consultant thoracic surgeon in Santosham Chest Hospitals and Apollo Hospitals, Chennai. Welcome, sir. Sorry, sir.
Good afternoon. I'd like to thank the organizing team, Dr. Pallavi and Dr. Diwan, for giving me this opportunity on surgical approaches to superior sulcus tumor. It gave me an opportunity also to read up something about it. So a superior sulcus tumor is a bronchogenic carcinoma developing at the apex of the lung, invading through the tissue contiguity into the thoracic inlet, which is the parietal pleura, first and second ribs, adjacent first and second vertebral bodies, lower nerve roots of the brachial plexus, upper sympathetic chain, and stellate ganglion, subclavian vein and artery. Initially, it was described by Henry Pankhurst in 1932. It was first thought to be unresectable with a fatal prognosis. In 1961, Shaw et al. Published results of RT, followed by complete resection by the posterior approach. This approach is still used, and it showed some promising outcomes. Goal of the treatment is, if operable, goal en bloc resection of upper lobe with all invading structures, as in any bronchogenic CA, and if operable, neoadjuvant chemo RT followed by surgical resection is usual. So, the structures which are resectable are the ribs, transverse process, the vertebral body, lower root of the brachial plexus, stellate ganglion, upper dorsal sympathetic chain, the subclavian artery and vein segments. So, the unbridgeable limits are the brachial plexus above the C8 nerve root, which can cause loss of hand function, and extensive vertebral involvement and invasion of the spinal cord. So, as already mentioned by some of the speakers, the compartments of the thoracic inlet are the anterior compartment, which is in front of the anterior scalene muscle, middle compartment between the anterior and middle scalenus muscle, and the posterior compartment behind the middle scalene muscle. So, the contents are the subclavian vein and IJV in the anterior, subclavian artery, trunks of brachial plexus and phrenic nerve in the middle. Posteriorly, the lower nerve roots of the brachial plexus and the stellate ganglion are present. So, there are different approaches. This is what my topic is all about. The anterior and middle compartments are dealt with by either the Masoka approach, Dartwell, Gruntwald, or the cervicothoracic transmanubrial. This is what I'm going to elaborate on. Hemiclamshell and trapdoor incision. The posterior approach for the posterior compartment is the Shaw and Paulson approach, which is a high thoracotomy with or without an anterior extension. Anterior extension is given sometimes for better vascular control. So I'll just give a few points on each of the approaches. So the hemiclamshell is a partial sternotomy, and the thoracotomy is extended in the fourth intercostal space, and it is lifted up. This is the hemiclamshell approach. Trapdoor incision is a hemiclamshell with a supraclavicular extension. Okay, this is like a trapdoor. Okay, Masaka is a hemiclamshell plus incision going to the anterior part of the sternocleidomastoid. So the Dartwell incision is a transclavicular incision approach and goes to the anterior part of the sternocleidomastoid. So the hemiclamshell, trapdoor and Masoka may be little more invasive, but has its own advantage. The dart well is good for approaching the vessels of the neck, but causes shoulder girdle dysfunction and deformity. So the Masoka hemiclamshell approaches, in these approaches, lobectomy can be achieved through the same incision. So the cervicothoracic transmanubrial or grunt world or the modification of dart well is the anterior part of the sternocleidomastoid and it goes to the manubrium and goes to the right up to the pectorodeltoid area. Then comes the Shaw and Paulson, which is for the posterior compartment. WATS or RATS hybrid approach is also done. I'll elaborate this in the later last part of the talk. So the cervicothoracic transmanubrial approach or the grunt-walled approach is done by positioning the patient in the supine position with neck extension and the head turned to the opposite side. Incision is a L-shaped incision anterior to the sternocleidomastoid up to slight lateral part of the sternal notch, extended to the upper part of the second rib, up to the deltopectoral groove. Incision along the anterior part of the sternocleidomastoid is done, and the sternocleidomastoid is retracted to expose the IJV. The pec major is erased from the clavicular insertion. Next, the first rib is divided at the costochondral junction, and the sternal head of the sternocleidomastoid is divided. It's cut here, first rib, and this is divided. Then the manubrium is cut vertically and laterally, leaving behind a 2 by 2 centimeter of the manubrium on the clavicle. This is better than the transclavicular approach because you're not cutting through the clavicle. This can be refixed. Then the osteomuscular flap is raised laterally, exposing the subclavian artery and vein. Then in this case, usually we heparinize. The next is when the subclavian artery and vein is involved, you heparinize and clamp them and divide them and reconstruct with prosthesis. Vein is usually reconstructed by a great saphenous vein, and artery by a PTFE. So that is done. And then the specimen is pushed along with the ribs and involved structures into the pleural cavity. Then the patient is positioned in the lateral position to do an upper lobectomy and a lymph nodal dissection in the usual fashion. Now comes the Shaw and Paulson's posterior approach. Here, the patient is positioned in the full lateral position. Incision is a high posterolateral thoracotomy up to the C7 level. The scapula is retracted all the way up, and the scalenus muscle is disconnected from the first and second ribs, giving access to the subclavian vessels and the brachial plexus. Open the second and third intercostal space and resect the chest wall by palpating inside. See, the second or third, here the third intercostal space is open, and you put your hand and palpate the tumor, and then you start resecting by palpation and vision. Anteriorly, the resection margin is about 2 finger breadths, and inferiorly, it's 1 rib with corresponding intercostal muscle inferiorly. Posteriorly, if the transverse process is not involved, it's at the costo-transverse junction. In certain cases, the subclavian artery may be reconstructed, but in this approach, the vascular, the vessels cannot be reconstructed very well. So, a special hook-formed extension from the previous incision anteriorly to the sternoclavicular joint is done, and the muscles are retracted up. so that we can approach the vessels, and if vascular resection and reconstruction is to be done, it can be done. As a rule, 1/4 of the vertebral bodies with no more than 2 adjacent vertebral bodies can be removed without affecting the stability of the spine. This is for when the vertebral bodies are involved. This is the common rule. But in certain cases where there is extensive resection is needed, help of experienced spinal surgeons who can do laminectomy using the cage, etc., their help is taken, and spinal stabilization, more extensive resection can be done, and stabilization can be done. So coming to VATS or RATS hybrid approach. For posterior tumors, usually VATS or RATS lobectomy, in the usual fashion, whatever method you use, with the systematic mediastinal lymph node dissection is done, leaving behind the involved chest wall. Just remove, you disconnect the vessels, bronchus, fissure, etc., and then follow by posterior Shaw-Paulson's approach, where you do the high postural thoracotomy and disconnect the ribs and etc., and then you push it inside and you pull out the specimen through the posterior approach. Here you avoid rib spreading, that's the advantage. For anterior tumors, the Grunwald approach is followed first, and by VATS or RATS and then followed by this is a lobectomy. So coming to the conclusion, superior sulcus tumor is a rare form of bronchogenic CA, about 3 to 5%. Posterior is more common, 2/3 of it. It requires a multidisciplinary team approach. Surgical approach for this tumor is individualized and needs to be planned depending on the location of the tumor. Radiological investigations, including MRI for brachial plexus involvement, and newer technologies like 3D printing adds value for surgical planning. Thank you.
Any questions? Yeah. Yes. Give him the mic. Some mics here also.
Rajiv, it is very crispy and very clear presentation you have done. Do you like to have neoadjuvant chemotherapy or radiotherapy? Any routine procedure for that?
So this is I read about this recently only. So in operable tumors, you give that is no meds and only N1 stage is there. You give preoperative RT and chemotherapy, followed up by this surgery according to where the position of the tumor is.
Okay, thank you.
Any experience of any of these approaches yourself? Because Dr. Raman Deshpande mentioned that he likes the Mesoka approach the maximum.
To be honest, I've with Dr. Rajan, I've assisted him in this surgery, but myself I've never done this surgery. And last 4 years I've not even. And actually we have one case who came to us, and they've gone back to decide and come back.
Yeah.
Just now we are planning a posterior
this
approach.
is a relatively rare tumor, not usually done. But usually, as Babitosh rightly pointed out, you give chemoradiation, downstate the tumor and operate. I've done a few of them, not a large number, and it's not usual tumor that comes for operation, because nobody wants to have a limb that cannot function. So you have to be very careful in selecting the cases. See, total loss of brachial plexus is a disaster. So we have to be careful, and in our country cases also come very, very late. We had a case we planned when Raji was there, radiation. By the time he had radiation chemotherapy, he had florid disease. Before we could plan surgery, he passed away. So this is a difficult tumor, especially in our country, since we see them pretty late. The number of cases each thoracic surgeon gets to operate becomes less and less. Whereas if you go to places like Japan or for the matter China, they have mass screening and they pick up very, very early bronchogenic carcinoma right at the GGO level. So from that, even these lesions are picked up much earlier. Now with more CT scan and more PET scans being done, we are picking up these lesions little earlier.
See, the last approach that you mentioned, the posterior approach, because we use a lot of that approach for, say, thoracoplasty, which requires the first rib excision. we go right up to there, the incision. So that we have some experience. That is some experience of that approach in that sense, not for these tumors, that how, what is the anatomy there. And whenever we do,
incision, we are not very familiar.
whenever we do the first strip resection, even in those cases, it's a little tricky business at that point of time. Yeah.
I have had the personal experience of meeting the French surgeon Dartwell many years ago, and he was the guy who all over Europe people flocked to him for these tumors, superior talcus tumors.
Yeah, it is a very mutilating operation, I should say. And what is the outcome? Ultimately, as you rightly pointed out, sir, that most of the patients come late. And then you go through a major surgery, a mutilating surgery like this, and what benefit is the patient going to achieve, or what have you achieved in
Depending on
the
the
end?
it's an R0.
So that is something which we have to think about before approaching this.
Absolutely.
Yes, yes.
Yeah.
Yes, Sri Krishna, it is absolutely right that it is a mutilating operation, but patients in tremendous pain. So it gives symptomatic relief, and if done nicely, at least for short term, almost all patients survive and have a meaningful life for some time. And these patients we used to get earlier when there was radiotherapy, chemotherapy was not advanced. In current years, we are getting less number, including myself, and we will get less number of cases. I hope with adequate radiotherapy, chemotherapy, surgery may be a little easier. But the palliative role is huge. It gives a lot of relief to the patient.
Sorry, we have had some bit of experience, but I would totally agree with Dr. Babatosh. It's more like a palliative surgery. So why can't we debulk, relieve the patient of his symptoms, avoid the complication of the brachial plexus, and then send him for radiotherapy and chemotherapy? I mean, it's just a thought, but we have been practicing that. Sorry?
Debulking is not an option in lung cancer cases.
No, these cases, when you take off the pressure from the nerve, you get a lot of palliation. It's just a thought.
Yeah. Do you have any thoracic oncologists here?
But I think oncologists, it's against the principles of oncology of doing this thing.
Yeah.
That's right.
We can do a downgrade it and then remove it.
I think
Better
the
chance of
consensus
getting
is to use
R0.
chemotherapy down.
Better chance of getting RC.
Okay, thank you.
So, as far as Pankos tumor, great presentation. It's a very pure anatomical challenge. The best prognosis is with surgery, and the best palliation is with surgery. No role of debulking. If you cannot operate, leave it. CTRT has improved our results, has achieved greater outcomes as far as the local control is concerned. So I think the best results is surgery, and it's a great anatomical exercise which should be done. So that's my point.
I think we can close this talk now. Thank you so much, Dr. Rajiv Santosham. Let us give him a big clap, big hand.
Thank you, sir. I thank the moderators for this discussion, sir. Next, we will start with RC Jain oration lecture. For that, I would like to invite on stage our moderators, respected Dr. Z.S. Meherwal, sir.
They are not here. Use it. No, not there. They are in the meeting.
Okay. Dr. R.K. Diwan, sir, our director, NITRD, and Dr. Rajan Santosham, sir, chairman, Santosham Chest Hospitals in Chennai.
And let us ask Dr. Shri Krishna also to
Yeah.
Dr. Shri
Krishna,
Dr. Shri
please.
Krishna, sir, please. I also request Dr. C.S.
Hiramat has come. Hiramat, come Hiramat.
Dr. Hiramat, sir, Secretary IACTS and Professor and HOD of the Department of CTVS at Sri Satya Sai Institute, Bangalore. I also request our respected speaker for the oration, Dr. Babatosh Vishwas, Principal of Vivekanand Institute of Medical Sciences, Ramakrishna Mission Seva Pratishthan, former HOD of CTVS at RG Kar Hospitals and past President of IACTS, to join us for his talk on development of thoracic surgery in India, lessons learned and the way forward. Welcome, sir.
Just say one or two words.
I would like to welcome Dr. Babatosh Vishwas, our past president of our association. In fact, I had the privilege when he was the president, me being the executive committee member functioning under him. A visionary by himself. In fact, I really appreciate the amount of efforts he had put in the national board curriculum. He put a lot of efforts in bringing out the thoracic specialty by itself, and always he used to guide. Not only that, in master classes, even though he was not well, he made it a point to see that the teaching doesn't get affected. He has good number of videos which he always wanted to showcase, and always active participation even during the COVID times, in spite of his health being not well during those days. And he is unique by himself in the entire association. His hair speaks by itself. I think.
I pulled his hair and saw. I'm going to send it to Guinness Book of Records. At this age, you will have so much of hair.
It's really amazing. I don't know what is the secret behind it, and I don't know anybody. I mean, a few of the residents always tell me that, sir, how do we grow such kind of hair? The residents asked me. I don't know. I told even I too don't know. I think you need to talk with Dr. Babitosh himself. With these brief introductions, he's a legend by himself. I think not much of introductions is required. Sir has done a lot of contributions towards thoracic surgery and also towards the welfare of the students of our association. That's very important. Over to Dr. Babitosh, please.
Thank you very much for this.
Last word, he was instrumental in starting the 6-year DNB thoracic surgery program in the country.
Thank you, thank you, thank you. I am humbled with this nice introduction. In fact, I didn't do anything great. It is the joint effort of all the people sitting here. I consider Rajan as Guru. And in a thoracic surgery, he is a living legend. I follow him, whatever he has done. And Hiremath is a brilliant person. Hiremath, Diwan, our Sri Krishna, and our friends sitting across the table. So thoracic surgery has come to this level. It's a great pleasure for all of us. In our early life, we used to get a small room, sitting couple of people, only the speaker and his assistant or resident, they were the only listeners. So those days are gone. Now we had very closely consecutive 2 programs, one is Chennai, one is here, and full of people, all youngsters have joined. It's a great pleasure for all of us sitting here, sitting also, all are very happy. And to talk about the legend, R.C. Jain, I feel humbled and honored. Such a great man. And I would like to remind you that Rajan gave the first oration in his name. So I feel humbled, I feel honored to get a chance to talk about him. And Dr. Jain was born in 1936. And in 1978, he joined as senior thoracic surgeon in RTBT after doing his FRCS from England. He worked in LS TB Hospital from 1984 till 1987. He was a visionary, and he had a dream to convert this institute into National Institute. And it is what we see today, sitting here, moving around this institute. This is his hard work and vision. He was a great teacher, and you will be happy to learn, especially Panlu sitting over here. He was considered as father of flexible bronchoscopy in this country. He was expert in surgery of tuberculosis and empyema. And it is due to his dream, this institute developed, we are sitting here. So all my homage, all my respect to him. It's a great honor to talk something in his honor. And as it is R.C. Jain oration, I thought, let me talk something what he has dreamed. He wanted thoracic surgery to reach an international level, the highest level, especially tuberculosis surgery. And you know, thoracic surgery starts with tuberculosis only. Had there been no tuberculosis in the world, probably thoracic surgery would not have developed. So the person who was expert in surgery of tuberculosis, so during the oration in his name, it is always good to talk about development of thoracic surgery. The development of thoracic surgery in this country, I am not going to touch a lot of history, but the way I have seen the development of thoracic surgery, I will just talk in brief, and I will try to create some interest in the audience, particularly those who are younger sitting in the audience, and I will try to impress them. The facilities to be trained and facilities and infrastructure to deliver their expertise is not substandard. There are huge scope to be trained in thoracic surgery, there are huge patient load, and all of you can have a brilliant career as a thoracic surgeon and you can be identified, distinguished as a person. It would have been possible if you were in some other specialty. Maybe I'll be inflating a little of my emotions, but I'm sure that thoracic surgery will take you to a greater height in near future. Just a couple of words. The thoracic surgery needs specialized knowledge and technical skill. It is not that other specialties don't require it. Yes, it requires, but since it's a very complicated place, heart, lung, esophagus, a lot of structures are there, so it has to be taken very seriously. You should have a lot of knowledge of the area, and you should acquire reasonable skill. You should be able to handle arteries, you should be able to handle nerves, you should be able to handle bronchus, then other structures. Since there are multiplicity of lot of organ in the small area, so you have to earn reasonable expertise. As I already told, the pulmonary tuberculosis history of thoracic surgery, and it was long back during the time of Hippocrates. It started, but here I will try to concentrate on Indian contribution. Our country started thoracic surgery quite long back, and I should start my talk by saying that I am indebted, and all of us sitting here must know about Madhuram Santosham, his father. He is the person who has got the highest credit of developing thoracic surgery in this country. So far as I know, he was a physician. He worked in rural place and he developed his own methods. He worked in sanatorium, developed his own hospital. He was a parliamentarian, but he dragged thoracic surgery to very, very high level. And that has been carried away by Dr. Rajan Santosham and his son Rajiv. So I express my gratitude to all of them to bring thoracic surgery to this level. And if I look at a little back, 1945 is the time when there are recorded thoracic surgical procedures done in this country, and gradually pneumonectomy, lobectomy, thoracoplasty, all these things were practiced. And Pune hospital, there is a hospital in Pune, military hospital Pune. They deserve a lot of credit. In record, they have done a lot of surgeries, and in many surgeries have been invented and practiced in military. They used to have a lot of diseases, accidents and non-accidents also. Pallavi. In 1946, you must have, because for the history sake, you have to you have to recollect the names of those people who have contributed substantially. Couple of names I should tell here. In 1946, Dr. A.M. Shah was working under Baliga in KM Hospital, Bombay. He repaired a injury of the heart. And Baliga himself does a pericardectomy. That was as early as 1947. And a young surgeon, Bilimoria, like it at PDA in Messina Hospital. Those days a very, very great surgery, extremely difficult surgery. Early 90s, 1902, Mashima, who started Mashina Hospital in Baikula in Mumbai. And Bilimoria was the thoracic surgeon, started the department of thoracic surgery very early in 1900 in Mashina Hospital. And he did first pediatric in 1949. K.N. Dasur, you must know him, he worked in PRBT Hospital, and he worked with Dr. Vora and many other cardiac surgeons, including R.L. Shah, J.M. Dosai. That time, thoracic cardiac not identified. It was known as thoracic surgery. Till the degree of Vellore, MGR University is given MC thoracic surgery. So thoracic and cardiac, this division came later due to specialization of all these specialties. So Nair Hospital, Bombay, bronchoscopy, esophageal pulmonary section, thoracoplasty, it has been recorded to be done since maybe long period, from early 19th. In 1999, K.M. Cherian, I know many of them must have seen him directly. He is a living legend. He does first double lung transplantation. And thereafter, Apollo Hospital, Chennai, they have done lung transplantation. Single lung transplant done in Global Hospital. And till date, maybe around 4,000 transplants have been done globally and more than 200 in India. These are very small glimpses that will help you to understand what is thoracic surgery. You have heard the name of Rib Bates, A.K. Basu, B.L. Gupta, Meherji Mehta, and many others who have done extensive work, and they took the trouble to gathering all person practicing thoracic surgery in Bombay meeting in 1970. That time I was just in MBBS. Rajan must have attended
I
or
was in final year.
you are in final year, but it is history and we have got a lot of interest about that. Without wasting much time in history, let me recollect a couple of names whom I could gather. Many of them might have left because large number of people have contributed. At that time it was not identified specialty. Somebody was good in lung resection, somebody has done traumatic lung, somebody has done other repair, somebody has done bronchoscopy, somebody has worked with foreign body. So a couple of names which I could recollect talking to my friends and my recollection. BP Chatterjee, he was working with dogs and dead bodies in NRS Hospital Medical College in early part of this century. Godrej Kodai, association with Godrej Audition is there, he is a great thoracic surgeon. P.K. Sen, later who became known after joining KM Hospital, he was a pioneer in transplant. Then K.S. Roy, there is TB Hospital in Kolkata. R.C. Jain, of whom we are talking now, M.P. Mehta. These are the people for whom we have a lot of respect, and couple of people who are still with us, we are very proud of them. One I already told you, Rajan is in front of me. And Dr. S.K. in Jaipur, he is sick. He was Vice President of Indian Thoracic Surgeon. He has contributed tremendously. He had done probably the very, very large number of bronchoscopy in this country. Stanley John, he was a great surgeon and he is a pioneer. He is known worldwide. Then Gopinath, his contribution should also be remembered. Sadhan Rai, he is the Vice President of our Indian Thoracic Surgeons. So, to name a few, lot of people of Bangalore, of Chennai, of Kolkata, lot of places they have contributed, maybe small part. It is not in record, but being person practicing thoracic surgery, our heads bow down in front of their contribution. That time it was very difficult surgery, very extensive surgery, no blood, no antibiotic, no intubation, no CT. It was all your ears and your hand and your courage. With that, they did excellent surgery. On that foundation, you are standing today. So this is my observation. It requires a couple of things. As I told you earlier, knowledge of anatomy and physiology, that is important. Just somebody cannot go blindly and cut something. And in all thoracic surgery, there is chances of bleeding. You must know how to control. Lung isolation technique is now standard, either double event tube or bronchial blockers. Asepsis and antisepsis, both you have to take care of asepsis and appropriate antibiotic and keeping lung expanded. So all these things are done. This has been offered by advancement of science as well as technology. Let me look at what the areas of surgeons need. There are lot many diseases in the chest. We are interested in a couple of them. Let us look at that will give you an idea. Tuberculosis, that is first and last. Till now, we cannot think thoracic surgery without tuberculosis. Those who had not worked in tubercular lung, tubercular chest, their thoracic surgery practice incomplete. I beg your pardon for that. So one thoracic surgeon must have experience in working with tubercular lung disease. Then commonly in this country we get hydatid cyst, lot of mediastinal tumors, lung cancer, different stages of which lot of discussion have taken place, and the congenital lung disease, cyst, and finally it ends in lung transplantation. So anybody who aspires to be thoracic surgeon, who wants to practice thoracic surgery, they should have these things in their mind. And for that, there are a lot of challenges and you should be ready to face the challenges. As a old man, my job is to point out those challenges, not to frighten you, but to make you careful, that how to equip yourself to face those challenges. And there is nothing to lose. If you have courage, you are trained, you have got enough knowledge, you will be able to do. So centers of excellence in thoracic surgery are required, and only some people are very, very fortunate to work in tertiary care hospital, major hospitals, capital cities. But thoracic surgery is not centered here. It is spread across the country. In a vast country of 137 crore population, it is scattered. In some very remote area, there will be chest injury, having a lot of ribs broken, patient will die of flail chest only. That is also our job. So people should be trained and work in all tier 2, tier 3 cities in rural areas. We have to develop, we have to innovate, that we can offer thoracic your knowledge to all these centers. So all these centers, I wish that they should equip with state-of-art diagnostic and therapeutic facilities, but you will not be fortunate to get all facilities. It is your commitment, it is your wish that we should be able to do it, and many things we have to innovate. Just like I can remember that many younger surgeons have now started VATS. And the way we started, they are doing the same thing, that you don't expect to have big instruments. Whatever rubbish instruments is thrown away in your OT, next room, long artificial, long tissue forceps, and whatever you have, you do it. Because same job you have to do, either by opening or to make a hole. Target is important. You have to get out of the pathology. A logistic and economic framework needs to be worked out. Patient care and treatment according to recommended standard. You cannot do rubbish. That I am doing thoracic surgery, so I do a pneumonectomy and lose the patient. Infected patient, lung is gone, so do pneumonectomy. No causal approach is there. And in thoracic surgery, you must remember, if it is malignant, that is different, guided by malignancy principle. If it is non-malignant, the elective patient, that patient would have survived for say 2 months, 3 months, 1 year. You don't have any right to kill him on the table. So don't do such venture which kill the patient. Particularly, I should remind her about tracheal reconstruction. It is very difficult surgery, very standard surgery. In my word, I say it is 0 to 100, 0 or 100. If you are practiced, you know the technique, you will save almost all the patient. If you do it casually, 1-2 cases a year, you will kill almost all patients. So if somebody is interested to do tracheal reconstruction, please learn it. Go to person, just like every time talking Rajan's name, he is sitting here. When I started tracheal reconstruction, I requested him, and he of his own flown to my place, was with me, and just guided me. Similarly, he has guided many people across the country. So all of us sitting here, Diwan does the same thing, he also does the same thing. So all of us do the same thing. So those who are becoming senior, please mind it, that it is your job to transfer knowledge without an interest. Because this speciality has made us great. So we have to contribute and give it back. Standalone centers or combined or cardiovascular centers or general centers, all are capable of doing thoracic surgery. Some surgery we have to do. And in current standard, whatever has been assessed, there's somebody doing thoracic surgery, if you want to develop center of excellence, there should be some arrangement intervention. Number is arbitrary. While doing thoracic surgery, especially advanced thoracic surgery, economic aspects must be taken into account. You have to develop cost-effective modalities. Today we are talking of robotic surgery, it is being done, but you cannot afford so much cost. It is not it is very great and difficult, it is not like that. It is not cost-effective, and I believe if large number of young guys take this surgery, automatically costs will drop down. We have to make provisions for cutting down cost. And public hospital should be enriched. And my request to all youngsters that please put your life, put your effort to develop public hospitals. Unless public hospitals come forward, unless teaching hospitals grow, there are a lot of constraints. It is not easy life. To get even a needle holding is difficult, to get antibiotics is difficult, to get a resident almost impossible. So unless you work in public hospitals, large number of centers grow, large number of people are trained, your dream of developing thoracic surgery will remain unfulfilled. There are thoracic surgery training programs in this country. Let me just, you know it, but still let me tell you. MCI recognized programs, the MCH cardiothoracic and post-DNB MCH or post-MS thoracic, and national board programs, the DNB 3 years, post-MS DNB thoracic and 6 years DNB. Either after MBBS, you can go to MCH and super specialties, combined program, or after MS, you can go for that. But after MS, number of surgeons are less, very few people get interested. It was our observation in early part of this century. Then with lot of travel of a lot of people, National Board came with a program of 6 years DNB in surgical specialties. At that time, I remember it is about 2005-06, we started thinking about that. Almost 3/4 seats of MCH in all hospitals, excepting AIMS, Vellore, all are remain unfilled. Now with the introduction of DNB 6 years program, the seats are getting filled. We should have number. We should have definitely quality. We are not compromising quality, but unless you get number, how are you talking of quality? So quality and number, both should come together. So both MCI initiative and National Board initiative, lot of positions are there for thoracic surgery. And the thoracic surgery DNB program, as you know, it was started in 2014 for post-MS candidates who has got interest for thoracic surgery. Somebody working in GI surgery, somebody pediatric surgery, somebody is general surgery, but they have got keen interest to go into chest, but not to do cardiac surgery. So this was the thought, and with that thought, the program was started, and as a just model, as a trial model, with 2 seats, it was started in Arjigar Medical College, and 2 people were the first. In Hindi, you can say Balika Bakra. So 2 people are picked up. One is Bhushan sitting here, and I am sure you accept him as a good surgeon. So he is an excellent person. He has talked nicely. And one girl, he could not come. That is Priya. These 2 are the first entrant in the program of DNB thoracic surgery started in Arjigar Medical College. Thereafter, these are the centers, having now 7 centers in this country, and with 12 yearly intake. But for a country of 137 crores, this number is nothing. So what has already talked, it may not do formal MCH or DNB degree, but people should be trained in thoracic surgery, maybe 3 months, maybe 6 months, maybe formal, maybe informal. Anybody who has got interest in thoracic surgery should be trained. Somebody, if takes a training of how to put a chest drain, that's a great training. In peripheral place, somebody has to put a chest drain, or somebody need to explore the chest. So whatever form thoracic surgery is required, it should be trained, it should be imparted to a large number of surgeons. Let me talk a little about Indian thoracic surgeon. Rajan sitting here, he is sitting president, sitting founder president, and a couple of us, we thought that it should be started, it should be a good platform, should be given to all surgeons and aspirants who wish to practice thoracic surgery. So 4th conference has gone, and now we are happy that this has given a right platform to come to bring all person who do thoracic surgery either by compulsion or by choice, with whatever percentage, 5%, 10% to 100%. Any person of thoracic surgery in any place, any setup, having interest in thoracic surgery, they have come under the same umbrella, and this is proved by the attendance in ISTS programs. And I wish in future you will take it to high level, and the way Hiremat is supported throughout, he is my close friend for a long time in Indian thoracic surgeon, and last several years our important discussion was how to start it, and you see his interest. We belong to the parent discipline, cardiothoracic surgeon, but we wish that wing should grow, and those people who has got interest in thoracic, let them practice thoracic surgery. Our job is to train them and make them complete thoracic surgeon. So let me talk about a couple of initiatives. I will just not take a lot of time. One is ISTS, Indian Society of Thoracic Surgeons. They are doing one national conference and couple of local programs, CME, workshop. So this is great training scope. ISCTS doing the same thing. National conference has got lot of thoracic discussions, and throughout the year there are a lot of thoracic program, as already Hiramat has talked in his talk earlier. And now I should, this is very important, this is my feeling, who should do thoracic surgery? This is my feeling, I may be wrong, please go through it. Either trained cardiothoracic surgeons, MCH, or trained thoracic surgeon, DNB, already 3 years training, they are the capable person, or person who are trained in general surgery, MS, DNB, FRCS, with interest in thoracic surgery. And if there is interest, they will have some experience. I don't want everybody to be MCH or DNB in thoracic surgery. It will not come in your lifetime. Somebody who has got interest in thoracic surgery and some exposure in general surgery, they are capable person. At least for a standard sake, let it be MS or DNB general surgery, basic platform, and then some training, and that is our job. All people experienced with sitting here, they will decide how to get them trained. For training structure, I have some idea in my head. The general surgery, general thoracic surgery, means surgery of mediastinum, lung, esophagus, blah blah, all the structures, that comes as general surgery training. The person who are training, who aspire to be thoracic surgeon, should have a broad outlook, that he should have reasonable training in all the scope. He should be having interest, and he should learn something about endoscopy. Maybe bronchoscopy, rigid, fiber optic, then GI endoscopy, some medial endoscopy, and some exposure in trauma, polytrauma, just hemothorax, pneumothorax, patient will die, how to put it in, how to manage it. So some idea about transplantation, there is futuristic view. Somebody working in thoracic surgery, after 10 or 20 years they will discard unless they know minimally invasive surgery and unless they are involved in transplant. These are future. You must do it. So anybody taking thoracic surgeon's career must keep these things in mind. Training structure, this whatever I have said, that starts with that, and finally robotics, critical care, all these things, and research and publication is most important. If you don't do some research work, if you don't put your ideas in written, in peer-reviewed areas, unless your work is known by other people, one is they will not learn and you will not be recognized. If by thoracic surgeons say 100 papers are published in different journals of the country and outside, people will know that Indian thoracic surgeons are doing great job. Somebody will contribute more, somebody will contribute less. You can do work with just chest injury, you can do work with chest drain or robotic surgery. Whatever end of surgery you are doing, that doesn't matter. But you must involve something, you must innovate something which should be suitable for your population. And everybody should have some reasonable training or exposure in basic radiology, CT, MRI, USG. These are the basic issues. And for that, what has been discussed earlier also, simulation has got a very, very important role. Everything cannot be practiced on human being. Now it is simulation age has come. Laparoscopy, people are learning on simulation. So thoracic surgery, robotic surgery, that can be learned in simulation is essential. And the concept of high volume, that concept you are all aware. This concept comes mostly from China. They have very, very big centers having several 100,000 cases. So we have to innovate how to do high volume centers. In this country, if you want to move for thoracic surgery, cardiac surgery training, you will get 100 centers doing large number of cases. For thoracic, high volume centers are infrequent. So I will encourage senior people and other policymakers to build high volume centers of thoracic. Somebody doing, say, 100 chest drain, yes, that is also center. Somebody doing 100 bronchoscopy a month, let them do. In a day, then what happens? The young beginners, they can spend 7 days, 10 days with their center and learn quite a little bit. So we need high volume centers having reasonable standard. And guidelines and auditing is essential. Unless you are self-regulated, auto-regulated, somebody from outside cannot whip. You should be honest, you should be auditing your performance, and that will help you, your quality improvement. And research and innovation is essential. When you are doing high-end surgeries, you have to innovate your equipment. You cannot throw away all the equipment. That's like rats or bats, all disposable you cannot throw. You have to innovate your equipments. So techniques should be innovated, equipment should be innovated, suture metal should be innovated, and let's say till today for MDR tuberculosis, persistent cavity, sick patient, we still do Clagett surgery. So you have to innovate your surgery according to the need of the population. We have to maintain our database. Whatever small work you are doing, every time we have discussed in ICTS meetings that our database is poor, we always quote for US works and then Japanese work. We should have our database. We are doing enough number of work, huge number of work. Our Diwan has pointed out, he has a lot of publication, lot of database of tuberculosis in this country. So whatever area of thoracic surgery you are working in this country, please maintain, help the association, take initiative to maintain database. Don't get shy. You have done 5 cases of chest injury, 5 cases of bronchitis, keep it on record. That will be information. It is not that you have to save 100% out of 100. Whatever small work, whatever rubbish work, whatever dirty work you are doing, everything should be recorded. If it is on record, younger people learn that this problem will happen, so I should be careful. So don't be shy and don't be I should not report whatever wrong has happened. Post-surgery education should be of high standard and high quality. Post-surgery doesn't mean only reading in books. And the current developments of medical education in national board level and MCI level, the basic thing what have been discussed at Government of India level and academy level, that all the available clinical infrastructure in the country should be utilized for teaching purpose. In Western world, they don't have medical college like us. They utilize all the clinical facilities. People work as resident, they take examination, they pass. There are rigid regulations definitely. And our structure is very difficult. If you want to start a medical college, you have to put 500 crores rupees, then one structure, then X number of faculties. All these things have happened in this country, and fortunately, last several years we are coming out from that. The outcome of this is national board programs. National board has devised a lot of programs. I have worked in both the levels, both national board and university level. It is very difficult or almost impossible to start a new program in MCI and MCI regulated programs. I can give you a small example, which Bengali we say kukurella soja kora. dog has got round leg, if you want to make it straight, immediately comes round. It never straightens. So it is something like that. If you want to new program, only institute by act of parliament, they have got the right. Only institute, PGI, NIMHANS, they can do their own regulation. They are not under the control of any university, not under the control of regulatory body. I realized after a lot of toil in working in national board and universities that MCI, NMC regulated programs, to introduce something difficult, you will pass your time. I don't say that you don't try, you do it. But outcome will be very, very far-reached. It will be difficult to do. But national board level, it is also made by Act of Parliament. In national board, since it is a central university, Menu Bajpai was talking earlier, it is a central sort of university, same exit examination, same standard. They adopted the great idea of Western world that any clinical facility is a place for training. For medical training, what do you want? You want patients, you want surgeons, you want investigations, you don't need a lot of books. That may be there, it is good. So any facility, be it private or in public, primary hospital, district hospital, taluka hospital, private hospital, all hospitals are rich with clinical material, they should be taken into fold, and these are the training centers. So let me conclude by saying the future of thoracic surgery is very, very bright. I see the faces sitting quite a good number of young talents, and I feel that they will have a very, very bright future, and we'll be happy all sitting here. We'll be happier when you will surpass all of them. You make them begar, useless, worthless. That is the day we are waiting for. Thank you. Have a nice day.
I think Dr. Bhabatosh has summarized a big journey and the situation in country so succinctly and so well. As it is an oration lecture, no questions are allowed here, but I will invite comment from Dr. Rajan.
I'm very happy that Bhabatosh gave this wonderful oration. I want to recollect a few things. Initially, when thoracic surgery started, we had meetings along with the Association of Surgeons of India. Then later, we had meetings with cardiologists. I have been associated with the Thoracic Surgery Association from 1974 when I started attending, and it's a long time being the past president, secretary, and I'm very happy Hiramat is here. He guided me a lot when we conducted this ISTS meeting. I went to him for a lot of advice and queries, and one thing great he did was he started the master class during the COVID period. When all of us were down and out, he took an initiative, got speakers from all over the country, all over the world, which benefited our PGs who had nothing to do. All of us, and we are all of us sitting here, must be grateful to God that in spite of the COVID, we are all sitting here alive and back to normal. I thank Bhabatosh for giving this wonderful oration. I thank Hiramat because he has been a very active secretary. Now he is planning on how to improve the DNB course, and is going to have a meeting. It is very important that the IACTS secretary answers every query. Every time I send him a query, within a few hours I get an answer. So we are very grateful for him to that, and I am very happy.
Can I add one line?
Everything
has been talked. Hiramat is very, very active, and for the growth of ISTS and thoracic surgery, he has got huge contributions.
One more thing I want to request him is, in our next ISTS meeting, we want to include the ISTS meeting in Bangalore, IACTS Thoracic CME, where both the associations, I let him put it to them, and we are very keen on it, and we hope that comes true. Because that is in fact we will try it this time.
I am giving you one suggestion. Yes, that you have done all hard work, yet many hard works are to be done. Yes, you have to convince people what has been started in National Board, that any institute having facility are capable of doing MSMD, MCH as well as DNB. This was talked million times, this was insisted by the government, it was passed in all regulations, but still, due to funny reason, from that end people stopped that. Current example, IGIMS Patna. There was Biswas is a vice chancellor there, he was a very active person. I know that place, Patna is close to my heart. We went there, we started DNB thoracic surgery. RGR was the first place where it was started. By silly reason, they sent a letter. After I have retired, I have known more than RGR, that institution cannot run DNB and MSMD in the same institution. It is never.
I think it's an oration. Let's just have a photograph here, sir.
Okay, thank you.
And let's conclude this oration. Thank you so much again. With lots of thank you. Citations and other things, but we have a photograph.
Thank you, sir. May we now invite the chairpersons for the next session, focused more on airway. Again, Dr. Bhabatosh, sir, Dr. Shalini, HOD Pathology at NITRD, Dr. Ashwini, HOD Department of Anesthesia at NITRD, and Dr. Gaurav Goyal, CTVS Surgeon from Baroda.
May we please invite Dr. Bal to kindly chair the session, sir.
I also request the chairpersons to give a brief about the session and the speakers, please.
Dr. Shetty, clinical approach to airway tumors, surgeon's perspective. Yes.
Good afternoon, everybody. Thank you, Dr. Diwan, Dr. Pallavi, for inviting me here. And a very difficult task to talk about in a thoracic meeting post-lunch after the Doyen has given a lecture and preceding another Doyen's lecture. So it is a tough thing to achieve. If you want to take a break, you can take it right now. So, whenever we talk about airways, I feel it's one of the most uncommon cancers. And the unfortunate part about this is that there is very rarely any early detection happening here. And we are the wrong breed of people here sitting to talk about this, because I hope everybody, we are the wrong breed of people here, because these tumors are essentially played around in the GP circuit and by many physicians before it actually reaches any of the surgeons here. It's very unfortunate. And that's why many people suffer. But sometimes I begin to think that if these patients had come to us originally, would we be in a position to actually detect these tumors? Or because in our country, if I order a CT scan for a wheezing, it is probably not justified. So it's easier to put the blame on the physicians that there was a delay, but sometimes I think if the patient had come to me 6 months ago with this complaint, I probably would not have done a bronchoscopy. So with these challenges, let me talk about airway tumors. Most of them are benign, malignant are less, but we talk about squamous papillomas, adenomas, some cartilaginous tumors, chordomas. Malignant tumors with which I deal the most of the time are adenoid cystic carcinomas, probably the best results that we can get, and of course the carcinoids, apart from the squamous and the mucoepidermoid. But how do they present? And believe me, all the symptoms that you're seeing here is probably very common in Delhi. It's probably very common. And do we really get them investigated? So when I was asked to give a topic, when Pallavi told me to talk about clinical approach, I really did not know what to talk about. How do we decide? How do we decide which investigation to be done? Or how do we guide, say, a physician or a general practitioner or probably our endoscopists to which would be the best way to diagnose this. Treatment, yes, all of us here are probably experts in treating this disease. But the problem is, how do we approach this? Well, I think I am also trying to find an answer to that. But what are the options? X-ray chest. Believe me, X-ray chest, nothing is detected. So unless if a patient of dyspnea comes, you do an X-ray chest, none of the airway tumors are going to get detected. If a patient is go-out cough, the only thing that we can do is probably an untreated, so a patient who is not relieved by cough of more than 2 or 3 weeks origin should get investigated and probably get at least a minimal low dose CT scan done, because many of the tumors are detected, and our experience with COVID especially have helped us in understanding that a lot of these small tumors, the small nodules, early tracheal lesions, I operated quite a bit in COVID, thankful to all the CT scans which were getting done. So that gave us some idea that this is going to help us in diagnosis some of these patients very early. Is wheezing, which is not getting treated. Most of them end up with a lot of steroids. Is it going to get controlled? No. In our country, the unfortunate part is, when we were studying, I do not know about what is happening in the curriculum right now, we said that if you don't know the reason, treat it as tuberculosis. Unfortunate. If you do not understand anything in our country, it is tuberculosis, and that somehow the teaching has changed, but people who are practicing still haven't. And when it comes to that, it's so difficult so that we hardly operate 10 or 15% of all the lung carcinomas which are diagnosed. Most of them come with stage 3 and stage 4. Similarly, hemoptysis can be maybe because of a tracheal tumor, maybe because of some granuloma or COX. Still, that is an important thing. Of course, striders cannot be neglected. So when people told me that if we had a wish and God gave us a chance as to which is the cancer that you should probably get, and if you are destined to get, so the answer we used to give was papillary thyroid CA, a well-differentiated papillary thyroid CA, a very early vocal cord cancer, because probably the stridor or the change in the voice is probably the first thing that you detect. But unfortunately, lower down, a stridor comes relatively late. And it's not that easy and challenging. Whether a CT chest helps, it does help. How much we do, we don't know. So clinical approach becomes a very difficult thing. Carcinoid syndromes, believe me, it's one of the most favorite questions asked in undergraduate, postgraduate, super specialty. Everybody would like to talk about this carcinoid thing. It's amazing. But when in real life practice, I don't know how many of us actually see these syndromes. And even if you see these syndromes, you fail to connect that there might be a problem with it. And over-enthusiastic bronchoscopists sometimes get it. We fortunately detect quite a lot of carcinoids, and we have done quite a lot of surgeries. Both of these X-rays here have some deformity, have some problem. Believe me, I was not able to see it. I'm sure your amazing eyes would probably detect them. But I could not in the first go, and I have to accept that with complete humility. And that's a problem, because you're going to miss small lesions, small deviations in an X-ray. A CT scan is probably easier because all of us are comfortable more than an MRI in detecting, especially in HRCT. Let us look at the small lesions here, or here, or here. So, yes, it's a tough job. I have this unique problem, especially with the number of PET scan centers which have come across all our. Do we need to do only a PET scan, or do we have to do an HRCT? And I keep arguing with my colleague, especially Nikhil, because he's a big advocacy of going the standard way of doing probably an HRCT chest, detecting it, and then possibly a PET CT. And I would take a shortcut and say, why only to a PET CT? I think the debate would continue, but each has its significant role. And I definitely like to do a combination of HRCT PET. which gives me much more information than a regular CT. But then, would I be doing that? For every patient, we can't do. So again, I'm stuck. Do I do a bronchoscopy in every patient or an EBUS of every tracheal? The problem still is, and I'm still waiting my answer for actually getting the best way for clinical approach to bronchial tumors. Thank you. Any question? It's a good way to put a question to the audience, right? Sabita is here, so she can argue on my behalf.
I thought you just started and you quickly finished it, leaving the audience to decide how they want to investigate.
Give me an opportunity to talk to you.
Shishir, that's a wonderful summary. In your own clinical experience, which you said mucoepidermoid carcinomas you prefer to resect, you get the good results?
Oh, carcinoids are the best.
Trachea.
But the problem I'll tell you with carcinoid is it comes to you pretty late.
Yeah.
It's gone through a lot of resections before that. So I still, it has got a good prognosis, so I'm okay with it.
How do you see the competition from the growing interventional pulmonologists who snare it, debulk it, bite it, and then send it to you?
I think you need to have good friends.
Yeah.
And your friends, your pulmonologist should be your greatest of your friends, because without that you won't survive.
If you can face to face and talk to a pulmonologist, that makes a big difference, isn't it?
Talk reason.
Yeah.
Then it works.
Thank you.
Then it works.
Can I just speak?
Yes.
I think there were 2 points which you highlighted very, very well, sir. I think what we have found, some of us have found useful, is that if we take 2 chest X-ray films, one in inspiration and one in expiration, it can actually give you a good clue, because if there is air trapping distal to the tumor, generally the lung volumes remain the same, sir. There has been a CT version of that developed recently, especially for chest trauma, but we found it
to be very useful. The second thing I think which you emphasized really well was that it's the temporal sequence which is important. If your symptoms are not going to go away within a short period of time with adequate treatment, I think you must consider at the back of your mind a possibility that you're actually dealing with something than what is so clinically obvious. Right. And I thank you very much, sir, for this.
Pallavi, thank you.
Okay, thank you very much for the excellent deliberation. Let us call the Doyen again, Dr. Rajan Santosham. He will talk about tracheal resection and reconstruction, and nobody else can talk like him. Not only in this audience, probably across the globe. Rajan.
Good afternoon, chairpersons. Can I have the first slide? Yeah. Before I start, I would like to say a few words. I started tracheal surgery in the year 1990, the year my father died. And it has been a difficult, long journey, but an extremely enjoyable and pleasant one. During the first 100 cases of tracheal surgery, I had a lot of complications. But as I slowly started moving up and more, I learned to do the surgery better, and the number of complications became less and less. What are the inhibitors to tracheal reconstruction? Suspicion of poor healing, presumed limits of resection, maintenance of ventilation, less incidence of cases for the single surgeon, and absolutely no prosthesis available till date. When to operate on tracheal stenosis depends upon the site of stenosis and the distance from the vocal cords. Any stenosis 1.5 centimeters from the vocal cord are ideal candidates for surgery. In higher lesions, oblique incision has to be made anteriorly. The incision can go just before the vocal cord, but posteriorly it must avoid the cricothyroid junction into which the recurrent laryngeal nerve enters. Patients who are medically unfit due to advanced age, poor cardiac reserve, associated medical conditions, and patients who refuse surgery, fulguration and balloon dilatation is a viable option. The most essential for good recovery is maintenance of cough reflex, maintains importance of recurrent laryngeal nerve, maintains speech. The other steps to preserve the vocal cord is to keep the tracheal dissection as close to the trachea as possible and using bipolar diathermy. This is the anatomy of the larynx. You can see the thyroid cartilage and the cricoid. The recurrent laryngeal nerve enters here in the cricothyroid junction. So it is important that you don't cut this area, and if you want more resection, you cut obliquely and cut the lower trachea more obliquely so that both the ends match, about which I will be speaking later. Anesthetic management and securing the airway. A laryngeal mask airway is one which we use regularly. You can use it for fulguration and dilatation, or you can use an endotracheal tube proximal to the obstruction, tracheostomy for airway maintenance, femoral bypass 6 cases, veno-venous ECMO, I have not used it. Good understanding between the anesthetist and surgeon is mandatory in getting good results. Preoperative assessment and planning. Careful preoperative and intraoperative assessment is very essential. CT scan and 3D reconstruction very helpful, especially in skip lesions. Bronchoscopic assessment is mandatory. Bronchoscopy and CT helps us to take measurements from the vocal cord to the upper end of the stricture or tumor and associated inflammation, bronchomalacia, lower end of the tumor or stricture to the carina, which helps us in planning. We have to assess pre-op feasibility of surgery. Length of trachea to be resected without tension. It is better to remove less trachea initially. You should not land up in a situation with two cut ends of the airway which cannot be anastomosed without tension. In difficult situations, Montgomery T-tube becomes handy. This is an example of a critical tracheal stenosis. Tracheal exposure. It can be transverse cervical or a mediastinal approach or right thoracotomy. Any lesion 2 centimeters above the carina can be done by this approach, but lesser than 2 centimeters from the carina needs a midline. This approach can be used for small carinal tumors where you don't need much dissection, where you can get the carina here and operate. This is a skin flap is initially raised, and then you come to do a sternotomy, retract the trachea, and then you put a bronchoscope and see. And then defining the anatomy of the stenosed area and localize the stenosis. A bronchoscope is being passed and the site of obstruction is localized, and the needle is used to mark the site of narrowing. This was a patient who underwent 20 dilatations, laserization and fulguration, so that entire trachea became like bone. He had stenting, he had expandable stents, metal stents which were removed, but still couldn't get over his tracheal stenosis. The trachea has a segmental blood supply. So, trachea, distally it can be mobilized anteriorly, keeping close to the trachea and forming a plane just behind the innominate artery up to the carina. Posteriorly, it has to be carefully mobilized, separating the esophagus from the trachea by sharp and blunt dissection, taking care not to injure membranous posterior wall of trachea and anterior wall of the esophagus up to the carina. This is very, very important. Good pain management, injecting the cocktail of local anesthetic. This has been started after the advent of Rajiv and Ramasamy. Early feeding and ambulation, early usage of sequential compressive device, good physiotherapy, daily exercise and CT when necessary, post-operative bronchoscopy, and managing neck flexion. They should not acutely flex the neck, but just keep it in such a way that the patient doesn't hyperextend. In my early cases, because of acute neck flexion, I have had one case of quadriplegia. Any stenosis 1 centimeter from less than 1 centimeter from the vocal cord will need a Montgomery T-tube for recovery. Cricoid cartilage, as I told you, can be cut in a midline and a small segment can be removed. Costal cartilage can be used to bridge the gap. Use of mechanical metal stents has to be avoided in benign tracheal disease. It causes problems like inflammation, infection, granulation tissue, erosion of the trachea, and tracheoesophageal and tracheoinnominate artery fistula. Even silicone stents causes some amount of infection, and nowadays migration is avoided by bronchoscopically stitching the stent to the trachea. Repeated dilatation, fulguration and stenting, as I told you, leads to thickening and calcification of the tracheal wall, which makes tracheal resection surgery more challenging. This is an example of a stenosis. We are trying to cut it with the scissors. We can't cut it with the scissors. And a bone cutter, rib cutter, has been used to cut the trachea. It was so thick. This was because of repeated interventions. This was a case of a 20-year-old female with complete collapse of the lung post-tubercular. Bronchoscopy showed both tracheal and bronchial stenosis. In the trachea, subglottic stenosis was seen 1 centimeter below the vocal cord, total length of 2 to 3 centimeters. Tracheomalacia was noted below the stenotic segments. 9 months later, presents with worsening stridor. Rigid bronchoscopy with balloon dilatation and metallic stent was placed. 9 months later, worsening stridor, mandating intervention, rigid bronchoscopy, balloon dilatation, attempted silicone stenting, technically not possible because the stenosis was eccentric. Completely covered metallic stent was placed. Significant malacia again developed stenosis below. ATT was stopped after completing. This was sent to me by Dr. Ravi Mehta. You can see the vocal cord and you can see the severe stenosis. Follow-up bronchoscopy showed metallic stent in situ but granulation tissue 30 to 40% in the distal end. Balloon dilatation of the stenotic segment done and metallic stent removed to prevent further ingrowth of granulation tissue. Patient came to the hospital with severe stridor and was taken up for emergency surgery. Here air bronchogram showing you the critical stenosis, air tracheogram. You can see the severely stenotic area in the trachea and you can see complete stenosis of the right main bronchus due to TB. That is the trachea which has been exposed. The thyroid has been separated. You can expose it up to the thyroid cartilage. The thyroid cartilage has been cut. Cricoid is preserved. And you can see the posterior cricoid and the cricothyroid junction is preserved. And finally, a Montgomery T-tube was put because it was a high resection. This was the pictorial representation showing how the thyroid and the cricoid have been cut. And the cricothyroid junction is kept intact. Montgomery T-tube in position. And post-Montgomery T-tube bronchoscopy showing proper level of upper end of Montgomery tube just below the vocal cord. Now this was tracheal stenosis with left main bronchus stenosis presenting with stridor. A 33-year-old female, no comorbidities. She was referred to us from elsewhere. Complaints of progressive breathlessness on exertion and noisy breathing of 1 year duration. No other chest symptoms. On examination, she had inspiratory stridor, vital parameters were stable. Fiber optic bronchoscopy showed a subglottic stenosis with a pinhole stenosis of the left main bronchus. Complete stenosis of the left main bronchus. Here again you can see the stenosis of the left main bronchus. The irregular trachea, rigid bronchoscopy and balloon dilatation done elsewhere was attempted under anesthesia and failed. She presented with severe stridor but was stable. CT scan, irregular narrowing, 5.5 centimeter segment of trachea just below the vocal cords. AP dimension of narrowest was 5.5 millimeter and narrowest transverse diameter was 4 millimeters. Left main bronchus stenosis and occluded. Here you can see the grossly irregular trachea and left main bronchus stenosis. Under GA, balloon dilatation attempted. Scope and balloon could not be passed because of the critical stenosis at the level of the upper third of trachea. She was decided for surgical resection of the stenotic segment of the trachea. The distal length of stenosis was not clear even with CT scan. Aim was to resect the most stenotic segment. Until we divided the trachea and took control of the distal trachea and initiated cross ventilation, the patient was not paralyzed, but she was kept on spontaneous ventilation. Here you can see a needle being used to show the level of stenosis, trachea being opened, and a flexometallic tube being passed for distal ventilation. That is the tube. And the completed anastomosis. Post-operatively, she did well, no stridor. In fact, we had to do a sternotomy also, you can see, because it was a long segment. Mobilized and initiated on diet post-operative. 1, mediastinal vein removed post-operative. 2, subacute inflammation and fibrosis, mostly post-tubercular. Emergency tracheal stenosis, patient presents with severe stridor. Emergency bronchoscopy, fulguration and dilatation is mandatory. Femoropyramidal bypass I have used in 5 cases for severe stenosis. Hypoxia is to be avoided. Proper planning essential. If you are unable to secure the airway, patient develops cyanosis, bradycardia, arrest and cannot be revived. So you have to be careful. Femoropyramidal bypass. A 50-year-old male with OPC poisoning 2 months ago on ventilator for 15 days and a low tracheostomy was done elsewhere. Stridor worsened in the last 3 days. Presented with severe gasping and stridor. Emergency bronchoscopy and tracheal dilatation and fulguration was done with the patient in the sitting position under local anesthesia. Patient improved symptomatically and emergency tracheal resection and anastomosis done. Here you can see the fulguration and you will see the balloon dilatation. Rajiv did this with a patient sitting up under local anesthesia and the balloon dilatation. This was an interesting case of a child from Nigeria, 3-year-old child, traffic accident in 2019. CPR was done, shifted to the hospital, intubated. Unable to wean off the ventilator, so tracheostomy done. Child unable to withstand the tracheostomy tube and it was removed. In 2019, found to have tracheal stenosis. Planned to take the patient to USA but couldn't get visa clearance. Brought to us at Apollo Children's Hospital in 2020. Here is the total tracheal stenosis with the tracheostomy. Total length of trachea 6.8, stenosis 1 centimeter, vocal cord proximal to the stenosis 2.3 centimeters, distal point of stenosis from carina 4 centimeter. Preoperative bronchoscopy to evaluate the length of stenosis to evaluate the subglottic region. This is a patient with the endotracheal tube in position and you can see the granulation tissue, tracheal resection done. You can see the scarred trachea, you can see the intubation with a flexometallic tube during surgery, and here you can see post-operatively the vocal cords were intact. This was done with a laryngoscopy Patient did very well and went home speaking and happy. Post-operative course, extubated on the table, shifted to recovery, clear, voice intact, discharged on the 4th post-operative day. Congenital tracheal stenosis with ventricular septal defect, child had VSD and critical tracheal stenosis, VSD was closed and tracheal resection and anastomosis. That is the stenotic tracheal segment, measurements being taken, trachea cut both sides, and the length of trachea excised in the small child was about 1 centimeter. In conclusion, tracheal resection and reconstruction remain the best option for patients with tracheal obstruction. Patient selection has to be made very carefully. It needs careful preoperative preparation, anesthetic support, perioperative techniques and postoperative care. Newer techniques are promising but not yet ready for generalized use, meaning stents. Expandable metal shunt should be avoided in benign airway. After 3 weeks, stent gets impregnated into the tracheal wall and cannot be removed. An operable tracheal lesion becomes inoperable. Other complications of metallic stents are migration, infection, granulation tissue, TE fistula. The cooperation, once again, between the anesthetist and the surgeon is mandatory. This is Dr. Hermes Grillo, whom I had the association of meeting 4 times. But I had not seen a tracheal surgery, I had not seen a picture or a video. I had to start by reading the books. There was no YouTube, no videos, but it was a long journey. It was a difficult journey, but it was worthwhile. I have had the opportunity to travel from Trivandrum to New Delhi, to Varanasi, to Calcutta, to Bombay, to help develop tracheal surgery, and I am very, very grateful for the entire ISTS, the pulmonologists, the anesthesiologists, and my close friends like Babitosh and Diwan, and the guys from Bangalore who are going to do the next conference, Sri Krishna, and I've got a promise from our secretary that he will do the meetings together. I enjoyed the presentation. Thank you for giving me the opportunity. Last 15 years I've been ably supported by Rajiv, and last couple of years from Ramasamy, who also helps us with Hindi, thanks to his training in Delhi. Thank you.
Thank you. Any question or comment? One question.
I congratulate Dr. Rajan for a very long series of tracheal repair. On how many occasions you encountered bilateral laryngeal nerve palsy?
Bilateral?
Laryngeal nerve palsy, recurrent laryngeal nerve palsy.
In the initial period, my percentage of recurrent laryngeal nerve injury was high. But after the first 100 cases, I had very few recurrent laryngeal injuries. Initial place was a learning curve. Yeah.
How you manage them in post-op period?
You invariably, they get used to it for some time. You put a Ryle's tube, and after that they slowly learn to swallow with the vocal cord paralysis. Main problem of bilateral vocal cord paralysis I've had only in about 3 cases. If they are abductor spasm, it's fine. Once they go into adductor spasm, you have to have either an endotracheal tube or a tracheostomy tube. You have no choice.
What is the long-term solution?
You have to lateralize the vocal cord and make them learn to swallow.
Sir, that was a wonderful talk, sir. Finished, sir?
Yes.
Sir, you have met the father of tracheal surgery, Grillo. You are our father of tracheal surgery.
See, I had the privilege of meeting Grillo for the first time 30 years ago in a cruise ship in a conference. Manke was there in Japan. After that, I met him in the American College meeting. Once I go to Boston, walk in, he's walking. He's already retired. And one more time in Bombay. 4 times I met him, yeah.
My question is, you already said that you prefer a Montgomery stent in a stenosis just below the vocal cords, less than centimeter vocal cord. apart from that scenario, in which other scenario would you like to
When
use a
you
vocal
cut
cord?
too
Montgomery
much
tube.
of trachea and you cannot anastomosis without tension, you have to use a Montgomery tube.
Or when in doubt that the tension is too much also.
Yeah, then we have to put a Montgomery T tube and buy time.
Thank you, sir.
Sir, I would like to request the chairpersons to
Yeah,
kindly
She's
conclude.
got one more question, ma.
The last question.
Sabita.
Yes,
Arvind.
you.
Hey, Sabita has been standing for 2 questions.
Oh, two questions.
Sabita, you.
Sabita
Then you.
first.
Then,
First, I
okay.
have to apologize to Pallavi because we are delaying the session. Sir, just one question. Do you use flaps to buttress the repair?
Sorry?
When you do a tracheal stenosis repair,
Yeah.
do you use any muscle flaps or any flaps to buttress?
I never use a muscle slap unless I've exposed the innominate artery and the innominate artery is sitting close to the trachea. I used to skeletonize the innominate artery. Those days, the incidence of tracheoinnominate artery used to be high. Only in the situation where the innominate artery is rubbing on the suture line, I use the intercostal muscle to cover it. Yeah.
Thank you, sir.
Yeah,
Thank you.
come.
Yes, sir. You mentioned many names, Delhi, Bombay and Varanasi, where you went to help. But I must thank you on WhatsApp consultation who advised me, and we did a tracheal resection in a young girl you suggested with
Thank
a
you.
tracheal stenosis. My question is, sir, how many tracheal rings can be sacrificed? Maximum number?
Amma, see, in a young adult male,
Yeah.
more than half the trachea can be removed. Whereas a short, stout female, the amount of trachea that can be removed is very little. You have to be careful in removing. If there is any tension, always do a sternotomy. If there is still tension, open the pericardium, make a U-shaped incision on the pericardium around the inferior palm. These are the things. But still, if there is tension, use a Montgomery T tube to tide over the crisis.
Thank you, sir.
Thank you.
Thank you very much. Thanks for excellent lecture. Let us give a handsome praise. Pallavi, it is for you.
Thank you so much, sir. Thank you for concluding.
Thank you, sir. Our next session is on chest infections. I now invite on stage our chairpersons for the session, Dr. C.S. Hiremat, sir, Secretary IACTS, Dr. Rajneesh Gupta, HOD Respiratory and Critical Care, in charge of ICU and Sleep Lab at NITRD, and Dr. Anil Jain, Senior Chest Specialist at NITRD, are moderators for the session. Welcome, sir. I also request the chairpersons to give a brief about the session and introduce the speakers, sir. Thank you.
Yeah, I'd like to invite Dr. Ravindra Kumar Diwan, the current director of National Institute of Tuberculosis and Respiratory Diseases, the organizing chairman of the current CME. His topic is on the role of surgery in pulmonary tuberculosis. A very important topic where each one of us should be knowing about it.
Thank you,
Over
Dr.
Dr.
Hiremat,
Diwan,
and
please.
thank you, my colleagues and others who have gathered here. I am sure many of you are familiar with many contents of this talk because I think portions of it I have delivered several times. But I wish I would try to be not repetitive. I think about the incidence of tuberculosis and all, because it's a CME, I think postgraduates should know this much, that roughly 10 million cases arise every year, and out of that 1.4 for 25% is India's burden. So where does TB surgery stand in it? Roughly I have calculated, we don't have any data that 100,000 cases of active and post-TB sequelae must be requiring some kind of surgical intervention in India, but it is not being received because of paucity of thoracic surgery centers as well as paucity of surgeons dedicated to TB care. Nevertheless, TB surgery is a high cost intervention and it has moderate to high risk of complications. It should be contraindicated in patients who may respond to medical treatment alone. So that is why my two colleagues, Dr. Rajneesh and Anil Jain, are here. The decision to do surgery in a TB patient should not be left to one specialist. It should be almost a combined decision. The physician feels, look, this patient can benefit. And the surgeon feels, yes, and surgeons should be well familiar with what can be expected out of surgery. and this I have already mentioned, but what is important is that many cases keep on suffering from treatable morbidity. This I say from experience because there have been cases who were suffering from something or the other since 1983 and referred to me at 2011. I have seen those cases, and I, by experience, know that if those patients have received the correct surgical intervention early in the course of their disease, number one, they would not have suffered so much. Number two, my surgical approach would not have become so difficult. So what the surgeons involved in TB care should know, that indications and contraindications for surgery, timing for surgery, and older as well as newer techniques available. I mean, of course, all of us are reading video-assisted thoracoscopic surgery and robotic surgery, but you have to know good posterolateral thoracotomy, you have to know a thoracoplasty and other operations. All those operations which were devised by intrepid surgeons in the sanatoria era of TB management, they are still relevant in an occasional case, but occasional actually may translate into a number of cases if you do a sustained practice. So 3 indications broadly for students, either for diagnosis or when the disease is active, continues to be sputum positive, or the disease has become quiescent, patient is declared cured by the National TB program, and yet the complications and sequelae continue to make the patient sick. In diagnostic, obviously when you have to obtain washings from bronchial washings for smear and culture, or to exclude endobronchial disease. See, endobronchial disease is something which is, to which attention is not given much, but it is the most infective form of disease. If somebody is suffering from endobronchial disease, merely in his presence you can transmit bacteria. And we in our institute, many people of us have seen here. Bronchial stenosis and coincident malignancy. When other diagnostic modalities have failed, I think recently we were having a conference about diagnosis of TB in pediatric age group. Many pediatricians asked for bronchoscopic facilities to all pediatric centers because you may not be able, because you don't get sputum specimen from children. Similarly to sample suspicious lesions in pleura, lung or mediastinal nodes. And nowadays, actually one should never be requiring a thoracotomy to diagnose TB. It is quite easily possible by doing a VATS approach, but I do remember early in my practice that a patient with a very large mediastinal lymph node in a child, and at that time there were no trocars available which could go in such a small child. So we did a thoracotomy, resected the lymph node, and that again turned out to be tuberculosis. So tuberculosis is seen ubiquitously in India, so everything happened. And in active pulmonary tuberculosis. Now, this is an area Dr. Shri Krishna has actually given me a review to write on this topic, but in this slide I can summarize that indications as of now in my mind are when the disease is localized, which is amenable to resection, either localized to one lung or minimal disease if present in the contralateral lung. Polyresistant and MDR TB. Now what exactly is the role of lung resection in MDR TB? My physician colleagues as well as others are deliberating this to refine it further, because in the context of TB newer drugs are coming like BPAL regimen, bedaquiline, protamine and linezolid, which may change the scenario of indication. We are getting better and better results with newer TB drugs, and yet there are very specific situations where surgery should be offered, and our consensus is that if a patient of drug-resistant TB is started on treatment, at the same time a thoracic surgeon should be involved, that down the line this patient will be benefited if after 3-4 months we add surgery in addition to the correct drugs. Whenever there is a high degree of relapse based on drug resistance profile or radiological findings, so when sputum is positive despite 4 months of supervised chemotherapy, now if the patient is still positive, there has to be a local reason of the anatomy of involvement, or in addition, the patient could be drug resistant. So surgery should be considered. 2 or more relapses following chemotherapy and 1 or more relapse while on chemotherapy. Similarly, in an occasional patient who has repeated default or non-compliance, and the treating physicians think that this patient will relapse. Most often these patients are those who have a large cavity. We believe that drugs may not adequately penetrate the cavity, and even if patient becomes sputum negative, will become sputum positive again. So these are the best patients in whom surgery can be added. And then there is a large series. This is the largest series due to persistent cavitary disease, when there are complications and sequelae, lung or lobar destruction, when there is massive hemoptysis or secondary infection, and pneumothorax and empyema. All chest physicians and thoracic surgeons, I think, continue to be faced with this situation. How to manage it? We manage it by medical means as well as surgical means as and when required. Now, what are the reasons for resection in patients with cavitary disease? Actually, scientifically speaking, I don't have a proof that surgery helps. But it is something intuitive that we know the difficulty of antibiotic penetration in a thick-walled cavity. When the number of organisms contained within the cavity is too high, probably removal of the TB focus, which will act like a debulking, will help my medical management further. And one of the hypotheses which has been put forward by a WHO group is that after removal of a major TB focus, the immune response to residual infection may be enhanced, which is similar to paradoxical reactions occasionally noted during TB medical management. So what should be timing? See, I don't have a perfect answer, but I think preoperative anti-TB therapy for a minimum period of 3 months should be given to diminish the positivity of the sputum and to achieve optimal bacterial suppression at the time of surgery, yet avoiding delaying the surgery to a point where bacillary load is a perilous high. This brings to an important question which many people ask: do we have to wait for the patient to become sputum negative? No. Sometimes even in a sputum positive state, patient can be operated, but not immediately. Don't jump to surgery. Wait for 3 months, and if the patient is sputum positive or negative, if you think surgery can help, add surgery in addition. Because down the series I will show you that many patients have become sputum negative immediately after surgery. And there have been series which have shown bacteriological cure in many series, greater than 90% success. And the last meta-analysis I had was 2011. The treatment success rate of pulmonary resection for patients with MDR-TB was 84%. The rates of failure, relapse, death and default was 6, 3, 5 and 3% respectively. I think very soon we have a meta-analysis of this kind is due, but because of lack of many thoracic surgical centers, it is not possibly being undertaken. Now, just a brief idea about NIT-RD data, because that will give you a perspective of where it can help. So, from March 97, roughly 23, 24 years, we have done 1900 cases of post-TB sequelae. Just a minute. Yes. And out of them, the common indications has been hemoptysis, 1400, recurrent chest infections causing symptoms, 238, tubercular cavities and destroyed lungs, 641, aspergilloma, 241, and post-TB bronchiectasis, 600 plus. And these are the kinds of surgeries we have performed. Generally lobectomy, 1000 plus. Occasionally in almost 100 cases we have done a thoracoplasty, which is still relevant. So that is why I said older techniques should be still known by the surgeons. VATS associated surgery we have performed only 9. As many of my younger colleagues have shown that VATS is possible even in TB surgery occasionally, but these frontiers are yet to be broken and they have to be expanded further. Most of our cases have been done through a conventional open posterolateral thoracotomy approach. So what were the results? In almost all of these cases, we had control of hemoptysis. Minor rebleeds were seen in 39 cases. Massive or recurrent bleeding occurred in 12 cases, and which were managed by additional surgery of completion pneumonectomy. So overall, the patient's symptoms are very well addressed. So that's important. And for MDR-TB, I'm not giving you the data, but some of these cases, you see, these are the cases of MDR-TB, such a cavity. Now, you know, even if a successful treatment, these cavities will not go away, and patients will. So we decided in the beginning itself that we will operate upon these cases. Now, lobectomy, I think most of you have seen, but the important point is that vessels have to be, even in TB, vessels have to be dissected individually. There is almost no role of a mass ligation kind of technique, and this is doable with a little patience, but of course it requires a lot of, some kind of a training, apprenticeship under these kinds of cases, when you can dissect the vessels going to individual lobes and lung, dissect them and divide them in a safer manner. These are some of our operated lobectomy cases. So what I wish to say that even in TB, post-TB after lobectomy, the lung X-ray shows almost normal. It should become, the rest of the lobe expands and it should become normal. That is what we should be achieving. Not some space. Earlier we used to have a lot of space residual problems, but with good techniques those problems can be resolved. This is a, not very recent, but case of XDR-TB case, and this was treated by a pneumonectomy. This is how the post-pneumonectomy X-ray looks. It works very well. And this is the pneumonectomy procedure. What is important that there should be liberal. I said that TB surgery should not be done in compromised settings. Staplers, best suture materials, good operation theaters, and personnel of TB, personnel working in OT, they should be protected. So all those things should be available. And these are some of our operated cases of pneumonectomy. This is how the the hemithorax looks after pneumonectomy. Now this one photo I always show, this is a photograph of post-thoracoplasty. Upper 5 ribs have been resected, the apex has been mobilized and stitched here in the third intercostal space. So this keeps the cavity which was present in the upper lobe completely collapsed. This operation every surgeon should learn because it occasionally works very well, and patients become sputum negative or their hemoptysis is controlled. It is especially relevant when the disease is bilateral and you cannot do a lung resection. These are our post-thoracoplasty x-rays. This is how they look. This is an x-ray done for primary thoracoplasty, this cavity, and this is an thoracoplasty done for empyema space reduction. And lobectomy, vast lobectomy also done, but you see carefully the adhesions are very minimal. So if physicians refer cases quite early, probably we will end up doing more cases through a video-assisted thoracoscopic approach. But if they become late, then it is very difficult to achieve through this approach. Recent technologies. This is an important point that these are the minimal things which should be available in any center which does TB surgery, because we had a talk earlier of district hospital, level tier 2 cities, etc. doing it, but they should not be doing it in compromised settings. Double lumen endotracheal tubes, pediatric fiber optic bronchoscope, surgical staplers, tissue patch, fibrin glue and other hemostatic agents, organ beam coagulation, and digital portable chest drainage systems. This has beautifully altered our post-operative results because it takes care of the space problems very well. I would urge all thoracic surgery centers to invest in digital portable chest drainage suction systems, which is a very, very cost-effective solution. There are some contraindications to surgery in TB which have to be learned. Extensive cavitary lesions of both lungs, totally contraindicated. Similarly, lung function assessment, that is a separate topic. All of you know what are the values at which a lung resection should be offered. But in addition, pulmonary heart failure, 3 or 4, and body mass index only up to 40 to 50% of normal range. And BMI below 18, contraindication. You try to admit the case, give her food, him or her food, and then build up the patient. Severe comorbidities like decompensation in diabetes, etc. And another thing is active bronchial TB. I mentioned in the beginning endobronchial TB, because if you operate in an active bronchial TB case, the proposed stump will give way, and then there will be large bronchopleural fistula which will be difficult to manage. So TB surgeons should learn to do a bronchoscopy themselves also to see that their intrabronchial stump, etc., where they propose to make a bronchial stump, is healthy. Post-operative care is routine, but I will again mention that this digital portable chest drainage suction is a very important thing. Physiotherapy, respiratory exercises can never be spoken, one can never speak enough about them, how important they are. This is some of the published literature. I hope newer literature in the third decade of 21st century comes. This was in 2012, Ground and Calling the Surgeon, Role of Surgery in Treatment of Drug-Resistant TB. Another one was my own center's 15-year experience, which was published in European Journal of Association of Cardiothoracic Surgery. I think these are good topics. And then these are some of the videos. Some of you can click these pictures. These are the videos which we have done in our own institute and setup. These are the links to them. They describe every procedure, a TB pneumonectomy, a TB lobectomy, a TB decortication, a TB thoracoplasty. Everything is there. These videos we have carefully recorded. You can go through them. So in conclusion, surgery for TB should be considered after due deliberations and is a challenging proposition. In selected cases, it offers gratifying results. However, high degrees of skill and training is required for developing proficiency in TB surgery. And as I mentioned in my welcome address, that we are developing a 3-month fellowship program also we are offering, which is open to general surgeons, thoracic surgeons, cardiothoracic surgeons, but our preference is those who do get TB cases. Please do not take, we do VATS surgery, but please do not take it as a VATS fellowship. It's a TB surgery fellowship in which people, especially those working in state institutions, whether they are general surgeons who will commit themselves to some work in TB, are most welcome to join. Thank you so much.
Thank you, Dr. Diwan, for taking us through the role of surgery in permanent tuberculosis. Any questions from the audience?
Sir, we request to keep the questions in the end because we are 1 hour delayed. So we can have questions during quiz.
Sure. We'll go ahead with the
Sure, okay, thank you.
next
Thank you,
topic. Bol.
In this session, the next talk is by Dr. Nikhil Rane. He will speak on pulmonary aspergilloma, surgical options and indications. Dr. Rane, please.
Good afternoon, everyone. I start with I thanks organizing team to give me an opportunity to speak on this prestigious forum. I'll start my talk directly. I'm speaking on pulmonary aspergilloma, surgical option and indications. Pulmonary aspergilloma is a mycotic disease, fungal disease caused by Aspergillus species. These Aspergillus species are saprophytic mold, found worldwide, has a high sporolating capacity. So they are more in number, diameter of 2 to 3 micromillimeter, and they spread to human by inhalation. So the most common site for lodgement is the lung. There are numerous species like fumigators, flavors, niger, terulus and nidulans, but in humans most common is fumigators. These Aspergillus conidia inhaled is everywhere it is present, and everyone inhale it. But when in presence of intact pulmonary defense, the first line of army is macrophages. They fight against this conidia. If still not, then the neutrophil, they fight against the hypha. And in hyphae, which are the invasive form. And in intact defense, there is no manifestation of disease. However, when the host defense mechanism is impaired, this conidia germinates into hyphae, and these are the invasive form of the fungus. They invade into the vascular structures, vessels, causes infarction, necrosis, surrounding lung parenchyma, invades the angiogenesis. That's why angiogenesis, and around the lung and in the fissure or between the lungs and the chest wall, there is a new vessel formation. And later on, it may cause a fatal disseminated infection and extensive destructions. Incubation period 2 to 90 days. However, hydrocortisone increases growth by decreasing the oxidative killing of the aspergillus. So, in case of corticosteroids, there is in immunodeficiency, there is an increased incidence of fungal infections. The manifestation as in prevention is PSM we studied, it depends on the dose of infection, host immunity and presence of underlying lung diseases. The Aspergillus infection in human are classified by Hinson et al. Into either saprophytic aspergilloma, which is our surgery we are focusing, invasive pulmonary aspergillosis and allergic bronchopulmonary aspergillosis. Aspergilloma, as a surgeon, the incidence is unknown. 15 to 20% patient has a pre-existing lung disease cavities. The most common is the tuberculous cavity. The other causes of the preformed cavities are sarcoidosis, histoplasmosis, bronchiectasis, emphysema, cyst, cavitative malignancy, healed abscesses, pulmonary infarcts. As said, these fungal infection, they causes a form in a cavity. These are preformed cavity. The wall of cavity is lined by was thin to thick and surrounding infiltration into the structures. The inner surface of this respiratory is lined with the respiratory or metaplastic epithelium. These epithelium get erodes, and after erosion, the granulation tissue is richly vascularized by prominent bronchial arteries, and it bleeds and may lead to a hemoptysis. Sometimes this cavity are filled with the full ball, or the hyphae are expectorate into the sputum. The course of aspergilloma is determined by living or dead organism. In 10% with intact, they resolve, but in few they calcify into ring-like fashion and remain into the cavity. The clinical course, they may be asymptomatic, cough, hemoptysis. The aspergilloma patient present with the hemoptysis, mild, where it is less than 30 ml in 24 hours, moderate 30 to 50 ml in 24 hours, severe, it classified in two, either massive where 600 ml in 24 hours, or exsanguinated, means more than 300 to 400 ml per episode, or more than 150 ml per hour. The other causes are of the respiratory disease like wheezing, fatigue, dyspnea, fever, malaise, clubbing, weight loss. The diagnosis is by the radiological examination, the chest X-ray, CT scan, CT angio. The chest X-ray shows a cavitatory lesion with a fungal ball in it. CT scan shows the finding of chest X-ray get confirmed. It shows a cavitatory lesion with the fungal ball in it. It gives the condition of the surrounding lung parenchyma with not only the surrounding lung parenchyma but the pleural cavity with neoangiogenesis with using the angiography, so that your planning for surgery can be possible. In case of hemoptysis, the bronchial artery embolization along with the angiography is a therapeutic measure. The Belcher and Plummer classified into simple and complex aspergilloma. The simple were the isolated lung cyst, isolated thin wall cyst lined by ciliated epithelium, and the surrounding parenchyma is lung parenchyma is normal. However, in complex it is in the preformed cavities and surrounded by the diseased parenchyma, commonly found in immunocompromised patient. Mortality of the massive hemoptysis is 50 to 55%, while in surgical cases is says 1 to 23%. The poor prognostic factor in aspergilloma are progressive increase in the aspergilloma, bilateral disease, severe underlying disease with lung function, immunosuppressive therapy, HIV, sarcoidosis, a recurrent hemoptysis. The treatment is medical, surgical, local, and bronchial artery embolization. As in medical, the itraconazole and voriconazole may resolve the initial stages, but these patients, when the complications develop, require a surgical treatment. The surgery is the definitive treatment of aspergilloma, and the choice of surgical treatment depend on the careful estimation of benefit of the surgery and the risk of the surgery. The simple aspergilloma have a low risk, while the complex has a more risk. The indications are the patient having recurrent hemoptysis, single episode of life-threatening hemoptysis, chronic cough with systemic symptom, progressive infiltration into the surrounding lungs, and mass of when it is difficult to distinguish a mass from an unknown cause. The surgery is the treatment of choice: lobectomy, segmenectomy, or a wedge. In aspergilloma surgery for preoperative, I give there are two schools of thought. One says the antifungal has no role. Other says antifungal has role, but I follow that preoperative voriconazole for 2 weeks and postoperative for 3 months after medical optimization, and after preferably I prefer if the patient is tuberculous, the ATT should be completed. While doing this surgery, thoracic surgery, we isolate the lung by double lumen tube. But in case of aspergilloma, we take additional isolation of the lobe on the same side. So that the spillage into the same ipsilateral side to the another lobe of the aspergillus fungus should not happen. This I learned from Dr. Ali Zamir Khan sir. I'll show you the video where the insertion of Fogarty catheter to isolate the lobe on the ipsilateral side, where the Fogarty is inserted in a lateral position. The surgery is done either open thoracotomy, video assisted, or robotic. The surgical resection is difficult and risky is due to dense fibrosis surrounding cavity, obliteration of pleural spaces and incomplete or obliteration of fissures, enlarged or torture bronchial arteries or vessels, which makes the bleeding during surgery and make it risky. Fibrotic disease pulmonary parenchyma also makes the surgery difficult because it causes difficult to expand the remaining lungs. The inflammatory fibrosis, resection remain unable to expand. In that case, a residual pleural space obliteration procedure like tenting, decortication, muscle flap, omental transposition, and sometimes a thoracoplasty is needed. Mortality is significant. Significant post-operative complications are hemorrhage, BPF, infection, and residual pleural space. carefully to prevent recurrence after surgery, post-op antifungal is advocated, and if the histopathological specimen shows invasion of the fungal element, then post-op antifungal is recommended. The contraindication of the surgery when there is a case of bilateral advanced lung disease of aspergilloma, there are large transpleural blood vessels, failure to identify or localize the site of bleeding of hemoptysis, and continuous hemoptysis after previous surgery. The option, and in this case, a patient where surgery cannot be done, the other are whether we have a limited pulmonary function, limited severe pulmonary dysfunction, surgery not possible, systemic antifungal is ineffective. So the direct local intracavitary antifungal therapy or endobronchial therapy with antifungal agent can be can be used. So intracavitary treatment is CT guided percutaneously placed catheter into the cavity, and amphotericin B or amphotericin B plus acetylcysteine with aminocaproic acid seems to be successful. While the other in which the sodium or potassium iodide into the cavity has shown a successful result. Endobronchial therapy, where the instillation of amphotericin B via fiber optic bronchoscopy has shown a successful result, and a resolution of clinical improvement has been observed in this patient. But the disadvantage, the profound bronchospasm can occur during the procedure. The bronchial artery embolization, is actually bridging option in case of a massive hemoptysis, where immediate surgery is not possible. To buy a time from the resolution of the symptomatic relief, bronchial artery embolization is used. The recurrence is mainly because of the collateral, because the aspergilloma has a source from bronchial artery, intercostal artery, cervical trunk or pulmonary artery, so need to be selectively embolized, and is a bridge until the surgery in case of massive hemoptysis. The surgery has a good response, while in case of massive hemoptysis the death risk is more. So the surgery is the main treatment option in case of aspergilloma. Thank you.
Thank you, Dr. Nikhil. Nice talk on aspergilloma. I think questions we will have at the end of the session.
Thank you.
Thank you. So the next speaker in this line is Dr. Saransh Bansal. He will be talking on bronchiectasis. Okay, sorry. This topic is cancelled. So Dr. Pallavi Purwar, she will be talking on fungal and parasitic lung diseases of surgical importance.
Good afternoon. It is indeed a privilege to be talking here at the institute, which has been the only place that I've ever felt in love with in terms of thoracic surgery. So there are certain fungal and parasitic infections of surgical importance. I will briefly just give an overview of what all we should be thinking about. So the fungal infections that we have to be cognizant of are aspergilloma, mucormycosis, and rarely things like coccidiomycosis, histoplasmosis, blastomycosis, and cryptococcosis. In parasitic infections, it is very important to not just think about hydatid, which we all are very well aware with, but there are three other diseases of surgical importance: dicrofilariasis, paragonomiasis, and amoebiasis. So aspergilloma, as my friend Nikhil has just spoken about, it can be a simple aspergilloma or a complex aspergilloma, both of which are obvious indications of offering surgery. And we all know that for surgical aspergilloma, definitive treatment is resection if the patient has an adequate pulmonary function, and most guidelines are moving towards active management and not conservative management in patients with aspergilloma, whether simple or complex. Another important area that we don't often think about is Aspergillus empyema thoracis. This is caused by the rupture of the aspergilloma cavity into pre-existing chest space, which leads to a chronic empyema. And since we are so used to thinking of either bacterial or tubercular empyema, it is important for us to know that it is an important differential diagnosis when we are thinking of any patient with post-TB sequelae who presents with an empyema. These patients generally have a very high mortality rate and they respond to antifungal agents is very slow and it may also be incomplete. So aggressive surgical resection with antifungals is the treatment of choice. Not just the antifungals, not just surgery, but a multimodality treatment is needed. Next, of course, with COVID, we have all understood the importance of mucormycosis. So mucormycosis is a very largely highly progressive disease, whether it happens in the lung or in the nasal cavities. It starts mostly in the nasal cavities of the skin, but there is a significant number of patients who develop pulmonary mucormycosis, especially in COVID. We've seen mucormycosis happening and presenting with diffuse florid diseases, and these are very invasive fungus, so it will just invade not just into the chest wall but also into the mediastinum. Historically, the mortality rates were 65%, and it increases to 96% when the disease becomes disseminated, which can happen within days, not even weeks, it happens within days. It begins in the pulmonary parenchyma, spreads rapidly to the pleura, the diaphragm, the chest wall, it can go to the contralateral lung, it can go to all the extrathoracic sites, and it will lead to necrotic lung, which would not have the adequate blood supply, and hence antifungals will not work. But that does not mean that you can do aspergilloma surgery without antifungals. You have to give a cover of antifungals before you take patients of mucormycosis for surgery, because surgery alone has a very, very high mortality. It has to be a cover of antifungals in patients who have a limited disease. Another important infection to think of is coccidiomycosis. In coccidiomycosis, in the acute stage, you will just have a lung infection kind of a picture. So it won't it will just appear like a lung consolidation, but over time they will form a central thick-walled cavity. So the reason that I'm showing this is that it is important for us to know that this is one of the pathologies. If you see this, it's very common for us in India to think of any such cavity to be fungoma, which is most commonly aspergilloma, but yes, coccidiomycosis is one of the differentials. So these develop in only 5 to 10% of the patients, and indications of disease in coccidiomycosis are nodular disease, cavity disease, pulmonary infiltrates, or if there are complications like pneumothorax, hydropneumothorax, paranemonic infusion or empyema. And obviously surgery is straightforward, as limited as possible is the goal in benign inflammatory disease, just like for aspergilloma. Another important area that we should think of is this comes as a differential diagnosis of lung cancer. So it is important for us to know that a histoplasmosis can present like a solitary pulmonary nodule. And more commonly, what most of our senior surgeons would be well versed with is the presentation as a broncolith, and obviously fibrosing mediastinitis, which most cardiac surgeons come across in their practice. And it is important to know that histoplasma is a differential diagnosis there. So the main indication of surgery is to rule out pulmonary malignancy. In broncolithiasis, surgery has to be offered if the patient has intractable cough, persistent or massive hemoptysis, suppurative lung disease, or has developed bronchiectasis. Bronchoscopic retrieval is also one of the treatment options. However, it is important here to know that it is generally a calcified broncolith, and it is very difficult to take it out bronchoscopically, and sometimes you're liable to do airway injury. So you have to be very careful in the number of patients in whom you offer bronchoscopic retrieval. Fibrosing mediastinitis is generally treated with intravascular stents or airway stents, and if it is large, invasive, causing vascular compromise, then you have to do a SVC reconstruction, and if a patient presents with massive hemoptysis, sometimes even a pneumonectomy may be required. But this is a very rare indication. Most commonly we find histoplasma as a masquerading as malignancy, and we just need to know this, especially in today's times, wherein after COVID, so many CTs have increased, that we are going to have these benign lung pathologies coming up, and we have to know what we are dealing with. So we should know that this is one of the differential diagnoses. Another rare thing that can be an indication for surgery is blastomycosis. This is an acute pulmonary infection which is complicated by a paranemonic effusion or empyema. So it would generally present to you either as an empyema or as pulmonary nodules. And it is important here to understand that these present with mediastinal lymphadenopathy. So if you have a solitary pulmonary nodule with mediastinal lymph nodes, it is not always cancer. And surgical management is predominantly to rule out malignancy in these patients as well. Hydrated cyst, of course, it is most important pathology to consider. So we have to know that, know the radiological findings. We know this is a radiological diagnosis. There is no indication for biopsy in hydrated cyst suspected patient because of risk of anaphylaxis. So yes, we must all be aware of the pulmonary signs based on radiological signs of an uncomplicated cyst, of a ruptured cyst, and of an impending rupture cyst. So the upper two pictures that you can see, this is an unruptured hydrated cyst. It is a cystic swelling seen in the right lower lobe. You can see some specks of calcification here. Then when there is a signs of impending rupture, there will be a crescent sign, there will be an inverse crescent sign, or there can be a bubble sign. These are all named signs described well in literature. And when it is completely ruptured, then you have certain specific signs, like this is the Kumbos sign, this is the mass within the cavity sign, this is the water lily sign, this is the whirl sign, and this is the empty cyst sign, wherein the patient has coughed out the hydrated cyst in his cough. So we all know that there is no indication of surgery, medical therapy for hydrated cyst, and albendazole should not be given preoperatively because of very high risk of rupture of the cyst. So factors which influence the type of surgery would be whether the cyst is intact or ruptured, whether the cyst is a single or multiple, unilateral or bilateral, whether there is an associated liver cyst, and do you have a team who can do both things together. And we also have to look at the extent of destruction of lung parenchyma. However, it is to be very clearly emphasized that no matter which form of hydrated cyst, pulmonary resections should not be offered. We have to do an enucleation of the cyst, and with or without capitonage based on literature evidence. So the treatment options for hydrated cyst would be a cystostomy and capitonage, which we all are most commonly practicing. So we have to know here that you have to remove the cyst by using the Barrett's technique, wherein you tell your anesthetist to give positive pressure and the cyst gets delivered out. Some older techniques were the Hugon's technique, in which they did an enucleation of the cyst, and the cyst was removed with its germinative membrane intact without causing any perforation. So like what we do is we make an incision on the lung and just take out the endocyst, but Hugon used to prefer enucleation, which was not later preferred because of large risk of lung hemorrhage. And there are some rarer procedures like the Perez-Fontana method or the Contaxis method. Another differential diagnosis when we are looking at parasitic lung disease of surgical importance is dicrophalariasis. Dicrophalariasis again presents like a coin lesion, just like a histoplasma. And it has a central necrotic area, which is the clincher. The granulomatous reaction and the fibrous wall and the central necrosis is how we radiologically can diagnose dicrophalariasis. Interestingly, you have to note that these lesions have a high uptake on PET-CT. So this is again going to be a very important differential diagnosis. Any solitary pulmonary nodule with high uptake, don't always call it a lung malignancy. Sometimes it can be a rarer diagnosis. So the reason why we offer surgical excision again is to rule out malignancy. Then there is another rarer parasitic infection of the lung, which is paragonemiasis. The medical treatment is the standard of care, but yes, if you have persistent pneumothorax, pleural effusion or empyema, then you might need surgery. It is just interesting to note the radiological findings here. They just present like a small cavity or these multiple nodules. We just have to be cognizant of their existence so that we are able to plan our patient's treatment better. The last but not the most rarest of the phenomenons is the amoebic pleuropulmonary disease, which is very, very common, especially in North India. So every empyema that we get, if they have an associated liver abscess, it's very common to find a ruptured liver abscess with empyema in the chest. So most commonly this is by direct extension through the diaphragm into the right lower lobe of the lung, causing a pneumonia or a lung abscess. Patient presents with cough, pleuritic pain and dyspnea. And if there is a hepatobiliary fistula, then you will also have patient giving classical history of coughing out anchovy sauce pus. And rarely there can be hematogenous spread to other organs, which is very, very rare, and it is just to be noted. So this is the classical anchovy sauce pus, and this is a radiological image of how this can become a problem. This is rarer than what we see commonly. Normally what happens is that it's amoebic liver abscess, so we get a right-sided empyema. But I just put this CT to show that don't just always think there can be certain different tracks, and a left empyema is not, you cannot rule out an amoebic empyema if it is a left-sided empyema. Thank you.
Thank you, Dr. Pallavi, for your wonderful presentation on the infectious aspects in thoracic surgery. So, we invite our next speaker, Dr. Ramaswamy Rajendran. He is a consultant thoracic surgeon in Santosham Chest Hospital, Chennai, an associate consultant thoracic surgeon, Apollo Hospital, and he will be delivering his talk on role of surgery in chest wall infections.
Thank you, Chairpersons. My talk is on surgery for chest wall infections. My thanks to National Institute of TB Respiratory Disease. This is where I graduated as DRNB thoracic surgery. My sincere thanks to Dr. Divan, Dr. Pallavi, Dr. Saransh for the opportunity. This is Santosham Chest Hospital and Apollo Hospitals where I work with Dr. Rajan Santosham. So chest wall infections, they are relatively uncommon, and the true incidence is difficult to estimate. Proper and timely management of these infections is essential in order to avoid disastrous and life-threatening consequences. The challenges during the management of a chest wall infection, it is due to the chronicity of the infection, the patient's quality of life is bad. There is a potential risk of bleeding, and there is a difficulty in reconstructing major chest wall defects because of the lack of sufficient viable soft tissues. It can be classified as a primary or a secondary, where primary is a spontaneously occurring infectious process, which is due to the hematogenous spread of the microbes, and secondary is a consequence to a previous disease or a surgical procedure like a thoracotomy or a median sternotomy, or contiguous involvement from an underlying pulmonary or a pleural disease secondary to a chest wall injury. So what are the determinants of the outcome of a chest wall infection? It depends on the timing of any intervention, severity of the underlying disease, the immune status of the patient, type of the offending microbes, and the extent of the infectious process. The most common organisms being the Staphylococcus and Streptococcus, but in our country there is a lot of patients who have Mycobacterium tuberculosis as the causative for the chest wall infections. Less frequently it is Pseudomonas. Rare pathogens like actinomycosis, Aspergillus, blastomycosis, nocardiosis can occur. So the diagnostic approach, it involves two. One is the imaging, which shows the extent and the severity of the disease. It is either a CT scan, which shows the bony window, which shows the bone destruction, the fluid collection, the gas in case of a necrotizing infection, whereas MRI gives a more comprehensive view of the soft tissue involvement. Specific microbiological testing should be done for targeted antibiotic therapy. Careful and adequate sampling is essential. The sample can be a wound fluid or it can be a tissue specimen, and tests for the bacteria, fungi, and the mycobacterium are run. The treatment principles, it includes repeated and prolonged drainage, routine broad spectrum antibiotics to be started with, but we have to move on to a culture-based antibiotic for a more precise treatment. For complex and deep wounds, a vacuum-assisted closure, it helps to reduce the size of the defect. In certain situations, in order to reconstruct the defects, we need the help of a plastic surgeon to use a pedicle or a free flap. And in case of a necrotizing soft tissue infection, a radical debridement of all the necrotic tissue is essential. So under the skin and soft tissue infections, the most common disease entity what we see is the abscesses. It can develop in any part of the chest wall, but large abscess can occur in the subpectoral or the subscapular spaces. They can have potentially severe complications in the form of movement restrictions. CT scan and the ultrasound of the chest shows the extent and the severity of the disease. The treatment remains appropriate drainage plus minus a curettage and a debridement, and a culture-based antibiotic therapy. This is one of our own patient who presented with a swelling in the right pectoral region, and the CT scan showed subpectoral abscess extending up to the apex of the axilla. He had restricted shoulder mobility, was running high-grade fever. He had incision drainage on the lateral border of the pectoralis major. There was an organizing abscess between the pec major and the minor. Post-operatively, it was found to be a tubercular abscess. With ATT, he healed well. Necrotizing soft tissue infections are rare, but they are rapidly spreading, highly aggressive, they are often lethal infections. It can be secondary to an empyema, previous surgical procedures, or a chest trauma. The patients, they quickly deteriorate and they progress on to a septic shock. So a prompt diagnostic and therapeutic measure should be initiated. CT chest is a very valuable investigation which shows the extent of the disease. Early aggressive surgical debridement to remove all the involved areas, and a high dose of broad spectrum antibiotic, appropriate fluid resuscitation, and whenever essential, a cardiopulmonary support in order to keep the organ perfusion. This is one of our own patients who had left upper lobectomy for a mucormycosis during the second wave of the COVID. In the post-operative day 10, he developed a necrotizing wound infection, and this was rapidly progressive in spite of adequate surgical debridement. On day 16, he succumbed to the disease due to septic shock. Empyema nascitans is another common entity what we regularly see. It is a long-term complication of a poorly and an uncontrolled empyema thoracis, which is characterized by dissection of the pus through the soft tissue and the skin of the chest wall. It usually presents as a subcutaneous mass. The treatment is drainage plus minus decortication, especially if there is an underlying empyema. The soft tissue component may be lying away from that of the empyema pocket, so it might need a separate drainage. Appropriate antimicrobial therapy is initiated. The samples which are sent for investigations are the parietal or the visceral pleura during the decortication, or the wall of the abscess, and not the pus. This is our own patient who had a large right empyema with a empyema nascitans. He presented with a swelling in the right lateral chest wall. It was an organizing empyema with a calcified pleura. We removed approximately 2 liters of fluid along with the muck, and for a surprise, we were able to decorticate him because the calcification were not diffuse, it was scattered, and post decortication he had achieved a good lung expansion. Costochondritis, where there is inflammation of the costochondral junctions or the costosternal joints in the anterior chest wall. Usually it occurs as a second complication to surgery or a chest wall trauma. Patient usually presents with a draining sinus in the region of the cartilage. The anatomical features and the avascular nutritional supply of the cartilage makes it a chronic infection. The 5th to the 9th costal cartilage are fused, and this predisposes to contiguous spread of infection. So poor vascularity of the cartilage makes it less susceptible for antibiotic therapy. So importance of the surgical intervention in costochondritis is often underestimated. So radical removal of the involved segments may be essential. In the lower ribs, all the affected fused costochondral junction needs to be eliminated, leaving no bare cartilages in the infected area. VAC can be used as a bridge for reconstructive procedures. Pedicle muscle flaps can also help to close the defects in the lower chest wall. In the lower chest wall, usually there is a good overlap with the diaphragm, so additional stabilization may not be required all the time. This was a 64-year-old male who had a road traffic accident, a clavicle fracture which was fixed, rib fractures were conservatively managed. He presented to us with discharging sinus in the right anterior chest wall, which showed osteomyelitis and disrupted cartilages in the 5th, 6th and the 7th rib. So he was planned for a chest wall resection reconstruction either with a muscle flap or a bovine pericardium. This is the discharging sinus. A map of the right lower anterior chest wall was removed, and this is the underlying defect, but he did not require any flap. We were able to mobilize the lateral chest wall muscles to close it primarily. The post-operative wound scar. The histopathology turned out to be a granulomatous osteomyelitis. He healed well with 9 months of ATT. Sternoclavicular joint osteomyelitis, even though it is rare, it can occur after a blunt injury to the sternum. When untreated, there can be destruction of the articular capsule. It can lead on to mediastinitis. So proper drainage exposing the affected joint and debridement of the infected tissue is essential. This is our own patient who had a sternoclavicular joint abscess. He presented with redness, swelling, in the right sternoclavicular joint area. Initially, he had a incision drainage. The histopathology and the gene expert did not reveal any specific organism, but he came back promptly with another redness. So he had a second sitting of an incision drainage with debridement of the region of the first strip, and he was put on empirical ATT for 9 months, after which he healed well. Chest wall tuberculosis commonly occurs in immunocompromised host. It is secondary to hematogenous dissemination. Direct spread from the adjacent pleura, lung, or the lymph node. Patient usually presents with cold abscess. The common areas of the chest wall involved is the rib shaft or the margin of the sternum. The treatment is usually medical, and adjuvant surgical drainage and complete debridement is essential. A young male who presented to us with disseminated TB, and there was an osteomyelitic sternum, especially in the manubrial region, and a subcutaneous abscess with an impending rupture. Post incision drainage of the abscess, now he is on ATT. There is a discharging sinus which needs to be managed. This was a series of 2 cases in National Institute of TB Respiratory Diseases under Dr. Divan, where we had a left massive hemothorax secondary to erosion of the left internal memory artery by the anterior chest wall tubercular abscess. The patient presented with unstable hemodynamics. He required a left thoracotomy to take control of the internal memory vessel. So rare causes of chest wall infections are chest wall actinomycosis, where it's primarily a medical therapy, but surgery is used for treating complications like abscess, empyema, fistulas, and when the patient presents with hemoptysis. Nocardiosis is another rare cause of chest wall infection in immunocompromised patients, especially when the patient has antibiotic refractory empyema. We need to think of this, and the treatment is sulfamethoxazole and trimethoprim. Aspergillus infection of the chest wall are either a transcutaneous spread of infection or secondary to infections from the lung. With the entity of vacuum-assisted closure for complex chest wall wounds, the size of the defects are significantly reduced, which helps us to reconstruct in a second state. So the common indications for vacuum-assisted closure are contaminated, infected wounds, traumatic wounds, radiation-associated wound complications. The mechanism proposed is the VAC usually optimizes the local blood flow, reduces the tissue edema, increases the removal of the bacteria from the wound, and it also has a potential to increase granulation tissue formation. This case is, I just added now because today morning we had a discussion with Dr. Rajan sir showing post-diaphragmatic hernia, a patient developed a fecal fistula. So the fecal fistula, there was a drainage into the left pleural space. Left pleurocutaneous window was done in order to alleviate him from his sepsis. Later on, the fistula was managed by a laparotomy and a colonic resection. He was asymptomatic for approximately 16-17 years, and then he presented with a chronic sinus in the left thoracotomy site. So foul smelling discharge. CT scan showed soft tissue swelling. There is a pleurocutaneous fistula with underlying osteomyelitic rib. We did a sinus exploration which showed unhealthy granulation, and it was angry red, and we were not confident enough to take a biopsy. He was planned for a chest wall resection in a controlled environment, but the second time when the patient presented to us, the edges of the wound were showing everted, and it looked suspicious of malignancy. So the patient on frozen section was found to have a squamous cell carcinoma. PET scan did not show any evidence of distant disease. He is right now undergoing radiation. A word on chest wall reconstruction. Avoid prosthesis and a mesh in an infected space. We prefer to use myocutaneous flaps or a muzzle flap, which may be pedicled or a free flap. The common flaps is a pectoralis major, transverse abdominis, latissimus dorsi or a serratus anterior flap. So to conclude, although chest wall infections are relatively rare, surgeons need to play a central role in the management of chest wall infections, as surgical drainage is often a central tenet of treatment. The severity of the infection range from minor and inconvenient problem to life-threatening situations. So an organized approach to management is essential. Thank you.
Thank you, Dr. Ramaswamy.
Thank you, sir.
Thank you for a very excellent talk.
Thank you.
Next speaker is Dr. Vijay CL. He is consultant, Department of Thoracic Surgery, NH-MSMC Narayana Health City, Bengaluru. He will give his talk on multimodality management of pleural empyema.
Thanks to chairpersons and thanks to Dr. Diwan and team at NITID for the invitation. I tried to cover as much as possible on multimodal management of empyema thoracis. As we all know from today's morning session that empyema is as old as probably mankind. The disease has been described since Hippocratic era, who also described natural history and management of empyema, including open drainage, which had a high mortality at that time, up to 70%. Etiology of empyema, multiple causes are there. Among thoracic sepsis, pulmonary disorders include pneumonia, tuberculosis, bronchiectasis and lung abscess, mediastinitis from probably esophageal perforations, extrathoracic sepsis extending into thorax including subphrenic abscess, liver abscess, traumatic causes like post-traumatic gunshot wounds and penetrating wounds, and post-surgical resection with the lung resections, thoracocentesis and biopsies. In bacteriology, in community-acquired empyema, the common organisms include Streptococcus and Staphylococcus, uncommonly E. coli and Klebsiella pneumonia. Increasingly, anaerobic infections are seen commonly nowadays. Among hospital-acquired infections, major bacteria include Staphylococcus and Enterobacterus, and Enterococci and Pseudomonas aeruginosa. Recently, the anaerobic infections are showing increasing trend, especially among hospital-acquired infections, including drug-resistant organisms, and slowly we are nowadays seeing more number of fungal empyemas as well. And not to forget, as mentioned, tuberculosis, including its MDR and XDR components as well. A few risk factors which predispose to development of pneumonia and empyemas include old age, underlying major diabetes and cardiovascular diseases, poor oral hygiene and predisposition to aspirations and other immunocompromised states. Independent predictors for development of empyema in a known case of pneumonia include low albumin levels, low serum sodium levels with high platelet counts and high CRP levels. As we all know about staging of empyema, 3 stages are described. Stage 1, which is also called as exudative stage, where there will be outpouring of fluid due to increased permeability of the mesothelial covering on the lung. In stage 2, there is it's fibrinopurulent stage, where there is deposition of fibrin, which leads to formation of loculations and compartmentalization. And in stage 3 is an organizing stage, where there is ingrowth of fibroblast, leading to pleural thickening and entrapment of the lung. Sometimes we see late stages, including fibrothorax and sometimes even calcified pleura as well. On the left hand side, you can see stage 2 empyema, where you can see loculations and septations in different mediastinum areas and parasternal and paravertebral areas. And on our right hand side, we can see a organized stage 3 empyema, where there is contraction of the chest wall and pleural thickening and entrapment of the underlying lung as well. Coming to clinical evaluation, usually empyema that doesn't have any specific symptoms or presentation attributed to it, common to bacterial pneumonia, including cough, dyspnea, fever and pleuritic chest pains. Physical findings include dullness to percussion on the ipsilateral side and decreased breath sounds on the same side. Imaging, even till today, chest X-ray serves as a great screening tool for screening for effusions. And ultrasonography has a greater sensitivity for fluid detection and also to detect loculations. And CT scan, probably with contrast, is optimal in detecting empyema, especially a split pleura sign on a CT has a diagnostic value for detection of empyema. This is a representative picture of ultrasound showing a free effusion versus a multiloculated effusions, which will change our approach to management in these cases. CT scan with split fluorescence showing separation of the visceral and the parietal pleura with accumulation of fluid in between, causing entrapment of the lung. Coming to role of thoracocentesis, diagnostic thoracocentesis is indicated in all suspected parapneumonic effusions. presence of pus or on gram stain and culture is diagnostic of empyema, or if a pleural fluid pH of less than 7.2 and a low glucose level and a high pleural fluid LDH level should prompt a thoracostomy drainage for removal of empyema. If any doubt, you can use Light's criteria for confirmation. Coming to touch upon antimicrobial therapy, guidelines mentioned for community acquired empyema, intravenous second or third generation cephalosporin with a metronidazole for anaerobic cover, or parenteral ampicillin with a beta-lactamase inhibitor might suffice in a community acquired empyema. However, in hospital acquired empyema or a post-procedural empyema, the antibiotics should be aimed to cover MRSA and Pseudomonas groups. Wherever possible, culture-based antibiotics and local antimicrobial resistance patterns needs to be considered, and antibiotics should be managed accordingly. Coming to surgical management of empyema, the mainstay include to treat the underlying infection, either TB or bacterial infection, and evacuation of pus from the pleural cavity with drainage procedures, and important to fill up the space, residual space, preferably by an expansion of the underlying lung, and to restore the breathing mechanics. Additional objectives include to reduce the hospital stay, improve the quality of life, and reduce the treatment duration and loss of work days as well. Evacuation methods include chest tube drainage, plus minus fibrinolysis, surgical debridement, and thoracostomy. Space obliteration can be augmented by decortication, or sometimes if the underlying lung is not able to fill up the space, can consider myoplasty or thoracoplasty as described in the morning. Our specific issues to be addressed during treatment of an empyema include adequate antimicrobial cover for the underlying infection,